returned as undelivered, which led us to believe if that's a problem with Call Choice, which is a small segment of the private option beneficiaries, that wonder what the issue is with Blue Cross Blue Shield. So we raised the issue with Blue Cross, and in your appendix, I put towards the end a letter, or actually an email letter, actually it was a letter in an email that we got answering our questions from Blue Cross. And their understanding is it's an estimate about 5 to 10% of the time they're unable to locate individuals once they get the eligibility notice from the department and they send out their packet. So that's close to a little over 200,000 beneficiaries. And now you've got a big issue. And so then we asked Ambetter, and Ambetter's estimate was between 10 and 15% of the time. Now that brings up two issues, Mr. Chair. The first issue and foremost is the care coordination that's needed. The initial reach out or outreach to ensure they have proper primary care, that they have a network to go to when there's issues that they need for health care rather than using emergency room as their primary care. It's what one of the goals is. If you're not able to reach out to them, you can't get a care coordinator, and that was a concern of the carriers. Second concern for us was potential loss of revenue on payment on a PMDM basis per month when an estimate could be up to 20,000 beneficiaries, where payment is being made and they are unable to be located. Have some of them moved out of state, have some of them changed that. These are folks that, in the income level, probably changing addresses, but it's the responsibility to notify the state. Again, care coordination is the goal. And if they're not telling the state or the insurers where they live and reside, nobody can go out and give them the information they need to keep those costs down and to have good care for themselves and their families. That's why we raised it. We felt it needs to be looked at immediately. I then subsequently met with Director Seelig and his staff and the governor's office. At their request, they asked us to meet regarding a solution they were bringing to the table. And I'd like Director Seelig to talk about that solution. So that's where we are.
Go ahead, you recognize Mr. Seelig.
Thank you, Mr. Chairman. So this is a concern. In fact, it turned out to be probably a bigger concern than we realized, but the concern is twofold, as Mr. Stevens said. One is just if the carriers can't reach clients, they can't do the preventive work, can't make sure they're going to get their wellness visits, the types of things they'd want them to do, the education they want them to do. The bigger concern is if, in fact, the client is not at that address and may have moved out of state, we need to know it and take them off the rolls. What we do is, when we sign somebody up, we send them in writing a letter saying you're on the program, you're now eligible, and you need to come do the survey, take the health survey, et cetera. So at that point, when we send them that letter, if the letter doesn't come back as undeliverable, at least at that point, it was a good address, and it's within about 30 days usually that we then get that address to the carrier. So, it's a pretty short time frame from when we have verified the address to when the carrier is sending a letter to the same address, at least in theory, and it's coming back undeliverable. What we do when the carriers send us lists, and we've got, from what we could find, about 4,000 names that have been sent to us. When that comes to us, we send those names out to our county staff of that county and ask them to basically try to contact them by mail and see if it comes back. If it comes back, we cut them off the program unless we have some other way to contact them. If they've got a phone number, we make some effort to reach them. But if it comes back, we're going to assume they're out of state or something else has happened, and we take them off the program at that point. But the solution we're putting in place is we want to make it more, given that it's a bigger concern, then we realize we want to make it a more automated process where once a month we're telling the carriers, here's exactly how to let us know who's on your list that you can't reach. Here's the information we need. For example, we need to know the address you sent it to make sure what's on file with us is the same as what eventually got to them and that some characters didn't get dropped in the data transfer. But for them to tell us I think it's the 5th of the month, exactly who those people are, or if all of their care is being given out of state, we want to know about that because we want to check and see, have you actually moved out of state? Even if they've got an in-state address, we want to verify that. We're now going to use, instead of sending it to our county office staff, we're going to use just an automated mail merge process where we immediately send out a letter to the same address and see if in fact it comes back undeliverable. And if it does, we're going to take them off the program at that point. So it's going to be a more streamlined process to make sure if people have moved and we find out about it, that we can take them off the program immediately.
Okay, a couple questions. You said you got 4,000. How many have you removed because of their unable to find them after you're notified?
Yeah, I thought you were going to ask that. I don't know. We have taken over 10,000 off the program, but we don't have a breakdown of for what reason at this point, because what we do, we send those names out to the county staff and they work it as part of their caseload, and we have not up to now been tracking. The other part, I should have explained, the other thing we're going to do as part of this new process is track how many of those are taken off and have good communication with the provider.
So
But
when
I
you
can't
take-
tell you today which of those people have been taken off.
So moving forward, when someone is removed, will you be able to identify why they were removed?
Right. Yes, sir.
The other thing I have is, what we heard from Mr. Stephen was numbers from 5% to 25%, again, depending on which one of the carriers. Well, 5% of 200,000 is going to be 10,000.
Right.
So why do we only have, and it could be obviously if it's in the middle, if it's 15%, it's 150, 300,000, 30,000.
Right.
So why do you only have 4,000?
I can't tell you. I don't know if all the names are being sent to us, if some of them are in process, if other stuff gets worked out. When I asked the staff, kind of basically these names, the lists come in through emails to our staff, asked them to go back and compile. They came up with about 4,000 people. The challenge is, in some cases, the carrier will continue to send the name because they still can't reach them. But we may have worked the case, and if the letter doesn't come back to us, we can't, if the letter is deliverable, we can't take them off just because the carrier couldn't reach them. We actually have to be able to demonstrate that they weren't, that it's a bad address.
Is this new verification $100 million program that we've just talked about earlier today, does it do this? Does it verify address eligibility and remove people automatically because of that, or is this all done manually?
Well, the process we're putting in place will be, we're going to ask them to send us a file, and that will be automated to take them off. What we do have to do is, if the letter comes back, if we've got a phone number, we're going to call the phone number and say, have we missed something? So, our staff are going to try to make some effort, but not much. For the most part, as Mr. Stevens said, it's their duty to notify us if they've moved.
So I guess what I would summarize here, and we've got 5 on the list right now for questions, but I think we would agree that we've identified a problem here that you all are taking steps to address, just as we have the eligibility thing. So I would probably suggest that this, again, will be an ongoing item on the agenda, so you can give us a status report of whether or not you are dealing with and tracking these notifications that you get, because obviously it equates into a lot of dollars if it's truly not a legitimate spot. So let's go down the list here. We start with Representative Love. You recognize.
Thank you, Mr. Chair. Mr. Seelig, I'm going to ask you just a couple of things, but let me go back to just a basic premise. Now, we're talking about removing people off of insurance that we've provided, correct?
Yes, sir.
Is that okay? So, if I'm with Ambetter, if I have a policy with Ambetter, and you sent me a letter, and it's come back as undeliverable mail, then what you do is try to track me down, correct? Is that what you're
Yes, sir.
trying to do? Or are you
If Ambetter has sent you a letter and it came back, we're asking them to let us know. We will send you a letter because we have to kind of, as the state, have to officially make that contact.
correct?
If we get the letter back as undeliverable, we'll then cut you off unless, for example, we have a phone number and we can reach you there and try to determine where you are.
Okay, so, all right, so that's, I guess that's what I'm trying to get at, because just because I move doesn't mean I don't necessarily, not necessarily utilize the insurance coverage that you have provided. Is that?
Right, and you can move. We just have to know, the letter has to get to you.
Okay,
Because,
So-
in other words, so if you moved and you forwarded your mail, we're okay, and we may ask you to update your address. It's when literally we can't reach you, that we
Okay.
will take you off.
all right, well then, okay, I can understand removal at that time, but I was just trying to get a little clarification, because I didn't want to remove somebody just because they had a bad address, and we can definitely contact them, and they can definitely utilize the insurance. So
Right.
with that, Mr. Chairman, thank you. I yield my time.
Senator King, you're recognized.
Thank you, Mr. Chair. Mr. Seelig, first off, I'm gonna still try and look for a date for you to come on this issue
Sure.
with the Medicaid Audit Subcommittee, because I'm gonna find out some more information before you come. But, when we had the first initial signups, almost, I guess, 2 years ago this fall, when you had the huge amounts you were signing up, did the insurance companies any time tell you that, of this problem? When was the first time they told you of this problem?
I don't know, sir. I did not hear about it at that time.
So they never told you at any, you don't remember the time that they told you that, hey, these addresses are coming back undeliverable, there may be an issue or problem?
I don't. I mean, I assume from the start, there were probably some. I don't know when it became a volume that the insurance company said this is a real issue for us.
So they never communicated to you until Mr. Stevens here came up with this issue. This was never even on your radar screen?
They have not communicated to me. I'm not saying they didn't communicate with our staff. I mean, our staff constantly meet with insurance companies on various issues.
And your staff didn't tell you that there was a problem with this? Because if you know if there's 5 to 10% and they're having this, on the initial signups part, there was people and that problem was there right from the start, wasn't it?
Well, what my staff explained to me when we talked about it recently is that when they got those names, they've been working them as they've been getting them. It just hasn't been the streamlined process that we're putting in place.
But your staff never told you about this issue?
No, sir. Not that I recall.
Okay. The second part is, obviously, those people, if there was people in that initial problem, there was people having their premiums paid that never used it, probably, of these groups? There's people that never used this policy?
That's likely, Senator. I mean, there are a number of people who we can find who never used their policy.
So it could be several thousand people that's got this, we're paying it for a considerable amount of time, that are never using this. Never using medical services in Arkansas, or never using their card, or,
Yes, sir, but there are a number of people who don't use, who we do know where they are, who don't use, I mean, the insurance is in case they need it. We have members who don't go to the doctor until they get sick.
okay. So your staff never told you about this problem. The insurance companies never told you about this problem.
So let me be clear. I mean, not that I recall in terms of a problem. I mean, what would come to me would be an issue that can't be resolved usually, or that they've got real issues with. What I understand from my staff was, as they got the list, they were sending them out to be worked. So I think from my staff's issue, this wasn't a major issue because they were sending them out to be worked.
The other thing is, during the debate process of the private option, we were promised this great verification system. Senator Dismang, Representative Burris, yourself, promised all these great verifications. It was going to be this airtight ship. I mean, it's a 180 from what you said.
I wouldn't characterize it that way.
Well, the other part is about, it's for the working poor, but yet there's probably, 40+ thousand on it that earn $0 income too. But I guess I'm going to be asking some more questions, so if you could get me a list of your staff people that are in charge of this issue before this Medicaid Audit Subcommittee, we'd like to know.
Okay.
Senator Rice, you're recognized.
Some of it I've got by listening to the last two questions, but is there any other verification other than the initial verification when people signed up? You're saying because you don't get their mail back, you presume they got it. Is there any other verification that the people got it? And my hypotheticals I'm thinking is there people signed up? I know of relatives that get mail for a lot of different relatives, and
right.
They're just not going to take care of their business and that and the other. Is there any other verification or security goes on that we know of?
Well, Senator, excuse me. I mean, we verify, for example, citizenship, that type of thing. But you mean verification of their address?
Yeah.
The only way we do, and it's true on the Medicaid program too, the only way I know that we do that is by sending them mail, and if it's deliverable, that's it. And it may be deliverable at their aunt's house. I mean, we have some people who are homeless on this program, and as long as they have an address where we can deliver the mail to them, that qualifies them from that aspect.
Doesn't have to be maybe their particular address, but that could be the reason you're not getting sent. And some of the things I see with different programs, because I'm on a state line, I see people working sometimes or have ideas they're working both states, and they've got relatives on both sides of the line, and I know some that get mail on both sides of the line, or I highly suspect they do.
Yeah.
So that's where some of this comes from. Thank you.
Senator Irvin, you're recognized.
Thank you. On page 40 of the response that Blue Cross Blue Shield sent, it says a carrier cannot update a physical address since the service area and associated premium is dependent on the DHS system of record to determine. Information is also emailed to the state. So the associated premium is dependent on the DHS system of record. So when does the premium kick in? At enrollment, at eligibility verification, or so that you can kind of so that we can determine a dollar amount. Can we determine a dollar amount if we look at this and say we're paying a premium on a person that we can't find that may have moved out of state, and how much money is that? When does the premium kick in?
So-
When do we start paying premiums on that person?
Yeah, the premium kicks in if you sign up for the private option today. The first, the initial coverage in kind of the interim period, while you're picking your plan or while we are assigning you to a plan, because you've got a chance, if you pick up, you have a certain number of days to pick a plan, and then if you don't pick one, we assign you, and you've got, I think, 30 days to change plans if you don't like it. During that period, you're on regular Medicaid, still at 100% federal funding, but you're on regular Medicaid. Once you're part of a plan is when we start paying the premium.
Okay, so that has to be a verification.
And in the meantime, is when we have sent you the letter saying, here's, I mean, for example, you need to choose a plan. If that letter comes back, that's knowledge to us that you're not at that address, and we would start to close the case.
Okay, so what's the time frame there? What I'm trying to figure out is how much money we're paying in premium that's not being utilized in services, and is there an estimate of that time frame that we're talking about, times however many people we're talking about?
Yes, Senator, what I can't tell you is for the carriers, when they send, taking Blue
Right.
Cross as an example, when they send a letter, I don't know how much
long?
effort they make and how much time they give. For example, before they would send something to us saying, John Seelig, we can't reach him. I just don't know, and I don't know if the carriers kind of have a standard amount of time. I think at least some of them use a verification system of their own through the post office or maybe through data companies, but I can't speak to that.
Right. I'd just be curious to see what that dollar amount is. See what I'm saying? I mean,
Yes.
if we're paying dollar amount in premium versus dollar amount in,
Right.
that could be captured in
well-
savings for actual services.
Yeah. I mean,
That's my concern there.
Sure.
And then is there any way to check, like cross-reference to check if services have been provided for that person, and to check then with providers on addresses? Because I can imagine if you're going out to the county level, there's some manpower that's being spent up there. But if, that way you can check to see if that person's actually here utilizing the program or not, maybe at a different address, but is being seen by a provider. Because a lot of times when they come in, they verify address and phone number information every time they come in. I mean, at least most people do. So I'm just curious.
If they're being seen by a provider, then the carrier would know that, because the carrier would be getting a bill from the provider. So I think the
Right.
carrier could say, here's people we couldn't locate, but they're billing, which is a good point. While these people, I mean, during the period there, we're trying to decide whether we can locate them, they've still got coverage. If they still may show up in an emergency room and have coverage, so you're still insuring somebody. What we don't want to be doing, as Mr. Stevens said, if they've actually moved out of state.
That's what I'm
Now,
trying to
if they've died, we check with vital records regularly. We have a data match with the health department's vital records, so we take them off the rolls if we find out that
Okay.
they've died.
If I can cut in here just
Sorry.
a minute. Senator Irvin, you got another question, that's fine, but here's, we got.
No, I don't. I'm just trying to
Okay.
figure this out on the
we got-
solution side of it.
Got you. We've identified the problem, and obviously, this is going to be something we talk about again, but members, we've got a long presentation by Mr. Steven that has to do with the Medicaid program that is significant, and I want folks to still be awake for it. So let's try to press through here, and if you have a couple questions relating specifically to this, get them answered, and let's move on. So Representative Hammer, you recognize.
Thank you, Mr. Chair. the issue is,
That was just the right length question there. Push your button again.
the notifications are being sent out. The problem is that they're not getting the notifications. It's not that they're not responding to them once they get them. That is the issue, right?
Yes, sir. If the notification comes back,
Okay.
right, as undeliverable.
All right, real quick, when they go, when they moved, but they show up at the ER and they get services because they moved or they weren't able to be contacted, what I'm trying to draw a line is we're dealing with a problem of delivery of the notification to the person versus whether or not they actually responded to it.
That's
Is that
right.
correct?
Right.
Okay, and so if they don't respond to it, or they don't get it, either way, they're gonna show up at the ER, the doctor's office, and there's gonna be an expense to that. That expense, does it then become covered by traditional Medicaid, or is it uncompensated care to the provider?
If we take them off the rolls, it's uncompensated care.
Okay, and
Now,
are we-
I mean, for the month that we've already paid the premium, they'd be covered.
okay. Are you doing anything that when they go into the ER, the provider, and they apply for services and it gets kicked back because, you know, there's no insurance there? Is that a way for us to be able to identify those people to try to reconnect with them in an easier way?
It might be, what I'm hesitating on is if they had a private carrier's card and went in to get coverage, we wouldn't know it. I guess the private carrier would know it if their system tracks when the ER tries to bill.
Okay.
And I don't know whether their system does that or not.
Then my final point is this, or question is, the private providers, what are they doing to help solve this? Because it seems like if they had a address at one time, they're getting the premiums, of which what I'm hearing is we don't know how much in the past. Maybe we can fix it to where we know in the future or eliminate it. The private providers, are they not able to participate or to provide anything and say, hey, we got a claim from John Smith who was previously kicked off, here's where he got his services, and are they doing anything in the process to help eliminate the problem?
When you say private providers, so I'm clear, do you mean
Blue
the
Cross,
insurance
Blue
carriers?
Shield, or whoever's holding the
Well,
card?
what we're putting in place is for them to let us know if they can't locate someone. We have not done anything if a provider, a hospital, calls them and says, we've just provided service to someone. I mean, the burden is on the client. Now, I would guess a hospital would say to the client, what do you mean you lost coverage? You need to reapply. And clients can reapply if they're still eligible. And that coverage, so they could still be covered. But we're not asking the providers to tell us. Really, the idea would be for the provider to tell the client, if you're not covered, you need to be, if they're eligible.
It just seems like we're going to see an increase in traditional Medicaid, or we're going to see an increase in compensated care, which is where this journey started in the first place. So it seems like I would just offer this as a friendly suggestion to the Stevens Group moving forward, that we need to get a match between the two to really identify where they are, or at least track that number, so in 6 months you'd be able to say 4,000 people equated to X number of dollars of uncompensated care, because that's going to be my hospital. It's going to be, you know, Dr. Irving. It's going to be, you know, these people that are going to be, we're back to them eating it again.
And if I may, real brief,
You bet.
the care coordination is really important too, to make sure you get that first quick connection. The carriers have asked for phone numbers. I want to make sure you all know that, because DHS does collect phone numbers. DHS has not been able to get the phone numbers to the carriers. There are issues there. Carriers have called and asked, and I've talked to the director and his staff, and it's too complex a process, they say, to give the carriers the phone numbers. That is an option we discussed. So there is a way to reach out, but DHS is using those phone numbers to reach out to these people so that they can find out, to make sure they get onto the system quickly, so you're not showing up and getting that uncompensated care expense, Representative Hammer, that you talk about.
Again, we've identified, I've counted 4 problems right now, and one of the things we want to do is not try to solve the problems right here today. We'll ask our consultant to bring those back and the agency to bring those back. Representative Meeks, you have a question?
I'll pass.
Senator Chesterfield.
Mine is very brief, Mr. Chair. Just remind us of our deadline. What is our last day to get this done?
To get our job done?
Our report done, yes.
Well, we have a couple deadlines. Obviously, I think everyone knows by the end of this year, we have a final report due, and by the end of next year,
The final report is due by December 31st, is that what
Correct.
you're saying?
Correct.
Okay, that's what I need to know. Thank you.
I hope we're adjourned by then.
Healthcare has never done it. Healthcare's never done it.
Okay, again, this will be an item that, as these items recur on the agenda, they'll be for you all to present an update and also solutions that you have that are trying to address these problems. And again, I'll summarize those at the end of the meeting today. Okay, let's move on to the next item, which is, Mr. Stevens has got a presentation here. As you all recall, when we put together the RFP, we put together a pretty extensive list of questions of things that the task force felt would help it as it tried to solve the problems that we face. And what you're going to hear, and Mr. Steven can address that himself, but what he's told me is this presentation is going to try to address most of those, maybe not some of them specifically, but I'll turn it over to you, Mr. Steven. And you do have that in your packet. Is it online yet?
Yes.
And it's also online for folks who want to pull it up. So, Mr. Steven, you're recognized.
Thank you, Mr. Chair. So the questions, there were a lot of questions. Most of them dovetail real nicely into the RFP, and we're going to be addressing some of the solution-based questions in our final report. So some of the questions I haven't been able to, or my team, get the information to you yet. As we start to develop claims analysis, we'll be able to get some information. What we thought would be really important is to answer as many as we can early on in the process through the data that we could verify. And we're going to go through this PowerPoint slide with you now. If you have questions, you can interrupt me. Richard Kellogg is here. I also have three members of my team that are here. Dr. Will Oliver, if you could just stand up if he's here. Dr. Oliver does a lot of the financial analysis for us. And Jason Melanson is here, who is a systems integrator. IT is actually working on the scrub with some of our subcontractors. And I'm not sure if Stephen Palmer is here. He may have had a meeting. Yes, he is. And Stephen Palmer was also healthcare director, healthcare policy director in Texas for the governor formerly. So they're here meeting with people as we're going through. So it's a very aggressive timeline. So I'll start with today's report. Really, you have the summary update, and you also have the appendix. And so there's a lot of little things in there. To some of you, some of the issues may be important, and you may want to follow up with our team down the road. Please do. Every email we get from the task force, we send out to our team, and we take very seriously. Do not hesitate to contact us if you feel it's important. We're going to address many of the questions. We've offered some of our observations in the update. We also are working on several substantive issues as we go through and identify the picture for you. We have seen early on there's a need, as we discussed today, to have improved contract and vendor management from eligibility to the program operation. We also feel that you need to start focusing some of your attention on the high-cost populations, long-term care, development disability, and the lower-cost populations, although it's very important. You've got to use your time wisely, but it's really that 80-20 type rule, which you'll see in some of the data. And I think it's important that you really focus some of your attention in the future, because we're starting to see some things that are important for you all. Comparison to other states. We're going to start introducing you to some of the comparison we've done to some of the other states, and we'll talk about that. And you'll see kind of where your state stands with regard to some of these other states. Also, I think the last slide is going to show you the multiple waivers you have. We keep talking about 1115, 1332. I'm going to show you the waivers you currently have today. And you, as a task force, if you believe there's an issue with contract management, can you imagine what it is managing 7 waivers? You need to start focusing your attention on one waiver. And that will save so much time and effort going forward. So we're going to continue to discuss that. Our initial observations, finance. Let's talk about this. This is important. And again, if I spend time, and I'm going to go as fast as I can, but these are some important observations for you. 2% annual growth in the last couple years, not bad. You can look at other states, and during the same time period, the growth in healthcare in Medicaid, hasn't really gone completely at high, substantial levels in many of the states. They've been pretty consistent with this, which is good. But you also had some years in 2008, 9, 10, high years. One year you had 10% growth. So something's going on in the program, and we're going to try to dig and identify what is it that's really helping Medicaid, Arkansas and Medicaid stay at this level, which is not a bad percentage to be at, by the way, with Medicaid. A significant amount of dollars is paid outside of claims. So when we start looking at the claims, we're going to see some of the episodes and some of the issues in the hospitals, but we are going to see in here significant dollars paid outside.
What does that mean exactly?
It could mean the contractors, like we talked about today, 300 some odd million. It could mean you're paying people to do mostly professional development, administration, and we'll get to the line items and show you, rather than paying for the medical procedure itself. The private option program now accounts for over 20% of total Medicaid expenditures. Most of your long-term care is provided in nursing homes at a cost that's more than twice assisted living and even greater than home care. We'll get into that, and I'll show you where you stand as opposed to some of the other states. Traditional Medicaid costs are more than the private option, and we're going to look at that. We've actually been able to get down to the per member per month amount for Medicaid traditional versus your private option, which again is following up on all the questions that you asked. Long-term services and supports. So when you hear the term long-term services and supports, LTSS in the industry, what you're talking about.
Let me just,
Yep.
also, I know for the benefit of Senator Chesterfield, who does not like acronyms.
Yes.
ABD down there is that aged, blind, and disabled, when that's the biggest cost
yes.
driver?
And yes, and every time, I'm sorry, Senator, but every time I put one, I'll try to make sure I explain it, and we'll refrain from it, but it's just so adopted widely in the industry that it's
Thank you.
difficult to do that. Absolutely. Yeah, can you write? So you look at the long-term care support services, LTSS. That is your ABD. Some states refer to it, Senator, as LTSS. So it's your age, blind, and disabled populations. Behavioral health, development disability, long-term care, high-cost populations. The initial assessment is that your nursing home placements are conducted by nursing home professionals. So you have assessments that are being done. We haven't looked at the addressed quality or the level of assessments. I mean, just the fact that the assessments are being done by the providers. That's a question, but I'm sure they're doing it in a very professional way. Developmental disability, there's a 50-50 split between resources in institutional care and those in the community. Now, that's a high percentage, by the way, with a high-cost population for institutional versus community in the development disability area. And you'll see from other states, some states have gone to 90-10, some almost 100%. Others have gone slowly to 70-30, 70 community, 30 institution. And there are ways to do that in an effective way, but again, it's really all about what's best for Arkansas. Arkansas does not participate in the multi-state rebate tool. We want to look at some pharmacy leveraging for you and see if there's some areas where you can save money down the road as you begin to start thinking about solutions. You appear to have a low percentage of opiate users. This is something my pharmacy expert is looking at, and we're now starting to get, hopefully soon we'll get the pharmacy claims, and we're going to find things. The one observation I'll tell you now is meeting with Bob Alexander at the state employee agency. He has a PBM that they manage. They also manage one at DHS. You probably have other departments that manage them. I know in the RFP you want us to look at collaboration between departments. That's one area right there. Why are you paying vendors to do PBMs and the state taxpayers are paying for all this? That's one observation. The procurement issues Martha so eloquently spoke about. We don't need to go into these again. The number of challenges, the contracting process has improved though. And she said that, she's meeting some folks who are doing project management at the department. And by the way, I do want to say that the level of cooperation from DHS has been extraordinary, has been excellent. When we request information, they send it to us if they have it available. They are working with Dr. Oliver almost daily to go through the claims database and to identify the MMIS system, the Medicaid Management Information System, to identify issues for you. So that has been good, as have been the industry as well, medical society, the hospital association, on and on. Initial observations, again, the PMO we talked about, and the eligibility system. Eligibility, I want to talk a little about eligibility because there's some additional things that weren't raised today. I just want to keep on the back of your mind. The redetermination issue that you're all very concerned about or interested in. The systems are going to present problems down the road for really wanting to do something different and unique in this state. For example, if the CMS has sent them a letter and said, in all states, that you are to redetermine under MAGI, the adjusted gross income, you are to redetermine once every 12 months, but no sooner. The federal government is telling the state, you cannot redetermine midstream. But if someone has a change of circumstance, gets a higher income, works somewhere where they start making money and puts them outside of Medicaid or outside of private option, it is up to them to self-report. So I asked the state staff, why can't you have a state wage database at Workforce, which we're trying to get access to and talk with? Why can't you have that database automate, integrate into what you're doing in your database and have an alert mechanism at DHS? Because if you have an alert mechanism, child support does this, and they do it with the state wage hire, new hire database. And if an alert comes up, someone's not paying their child support, they immediately go out and make sure that there's deduction from that goes to the children, to the employer. You have no such thing going on in Medicaid. So the example is, someone could find a job month 4 that puts them into the subsidy area, and you'll never find out about it, and you'll keep paying the PMPM unless they tell you on their own. That, to me, is as significant a problem as the other issues.
But is it your understanding that in order to do that would require a waiver from CMS?
I believe so. I have not asked CMS personally, but I believe you would have to. And which is something we're parking all these issues so that when we decide to give you a recommendation to think about going forward on whatever it is, 1332, whatever you do, let's put a lot of these issues, aside. Or you could have the governor today pick up the phone and say, I want to do a redetermination within 12 months. Why can't we do this? I mean, maybe CMS would give you that opportunity and ability. I don't know the answer. I will try to find out for the next meeting. But it just strikes me that you have the federal government telling you you can't do redeterminations midstream within a year.
Okay, Senator Chesterfield has a question.
Right. Excuse me for
Yes,
breaking your train because I'm finding this very interesting. Are you saying you can't get a waiver to cooperate with Workforce to determine salary, or you can't get a waiver for the 12 months?
The 12 months, Senator.
But there's no waiver needed for us to deal with
none whatsoever.
Workforce to determine whether a person has a job, that the same thing that we would use to determine child support.
Let me clarify that. We're trying to set up a meeting that Phil is setting up for us to meet with Workforce. I need to ask them if there are Department of Labor regulations or other issues there. So I don't know. The second answer is, I don't know if you need a waiver from CMS, but I am presuming you're going to. I read the letter, I read the regulation.
Thank you.
Okay.
That's all I need.
You have, project management role is a focus to look at in the future, and I know Martha mentioned that, so I'm not going to continue on Curram and the other areas. Health independence account is an observation, and I know it was important. It was legislation that was passed. We met with the CEO and his staff of the vendor that actually is handling that program for you all. And they're doing a superb job, in our opinion, in terms of managing that. But herein lies an issue, and it's one I want to underscore for you about contract management. So they negotiated a contract with you all, or with the state DHS, because the health independence account was important. It would pass law. They needed to get up and running quickly, and they gave a fixed price to the department. The first year was like $1 million plus to do design. The vendor has to stop midway. His staff have to, he hires new staff. He stops his opportunity development in other areas. He's already doing stuff for the state employees, but he performed and was able to come online and do it in the time you needed. And I give him credit, or his company, for that. However, he negotiated a fixed price for this year, and you're paying him $8 million for 10,000 plus cards that have been activated. And the number of people, because you took out the 50 to 99, have been taken out. So now you have potentially up to 40,000 that get notice, and only 10,000 plus cards so far have been activated, which means that if you look at it at a PMPM, do the simple math, you're paying him or the company about $66 a member per month, when in fact the state employee group here is paying him $4 to manage a true health savings account. And you ask the question, why did you do a fixed contract? And why can't you make some changes along the way? It underscores the issues we heard this morning that I know Director Seeley is going to be looking into with us.
So let me just clarify this. When you say we've got 42,000 cards issued and only 10,175 activated, are we paying that $66 per month for all 42,000 or just for the 10,000 that are activated?
You're paying for all 42,000 basically. But you remember, they sent out information. They mailed to these people. They actually, reached out to them. So there was some effort. And yes, you are. And that's what I'm getting at. There is no contract that basically says we're only going to pay for those that were activated. We're only going to pay this PMPM. We're going to have these performance measures. Nothing like that. And again,
what is the term of this contract, and are there any, where are we at on this thing?
You'd have to ask the department. We can find that out for you, but I think it's this year, this fiscal year, full year.
Okay, thanks.
And that this is all up to end of March, and they have more recent data. So, Senator, yes. Do you have a question, Senator? No, I just want to do the math. Okay. I hope my math was correct. The overall Medicaid questions, one of the first questions that the task force asked us was, give us, the amount we're paying for these services. So prescription drugs, 372 plus million a year. These are 2014, the most current full year.
Is this traditional Medicaid, general
Yes.
revenue,
Yes.
state portion of it?
Yes.
Okay.
This is total, by the way, for these services.
So this is the state and federal?
Yes.
Okay.
Yes, total costs, correct. Long-term care, you'll see, and that also is broken out, nursing home care, assisted living, mental health services, hospital care. Again, we're going to go into these in much more detail, but this is just directly addressing one of the questions that a member had. This question is the federal, someone had a question about the federal and the state share, and you'll see traditional Medicaid, you've got your federal share of 3.3, you've got your private option, and this is, again, the first year of implementation, 2014, it wasn't a full year, and then your total costs. And the reason we put some cost in the private option, which you would probably be wondering, why isn't that middle one zero, is because we tried to dig into the administrative positions and the cost to implement the private option. There was some state cost.
Okay, we've got a question. Senator Rapert, you recognize?
Thank you very much. And the overall Medicaid questions that you were just going through, it's very, very important. Obviously, we're so focused on the health, the hospitalization part, but that actually is dwarfed by the rest of the budget. I just wanted to ask, Mr. Chairman, I think this is the appropriate place to ask for this, because especially the nursing home coverage that you're talking about, are you aware of the Arkansas Long-Term Care Partnership Program?
We have not asked about it yet, but we are aware of that in other states.
Right.
It is on our agenda.
And we have it. It's actually, and I see some of the insurance department personnel here. Mr. Chairman, I would think it would be helpful to us to get a report from the insurance department on if they have numbers on how much that is actually utilized, because that is a great savings for people, because if they have, for instance, $500,000 of long-term care insurance coverage under that long-term care partnership program, they do not have to spend down completely for Medicaid eligibility. They actually, once they spend down to 500,000, that's shielded. It's offset by the amount of coverage that they have. And it would be interesting to see, and we can get into that later, but typically, we don't have a lot of conversation about that. I know I have a lot of conversation with clients about that program, because that's an incentive for them to buy their own long-term care coverage, which saves us a lot of money, typically. And so I just wanted to ask that if perhaps we could get them to give us a little detail, and it would help us find out, are people actually taking advantage of that, and is it actually having any effect on savings for us?
Why don't we include that in the August meeting when we're doing long-term
Sure.
care and nursing homes and all that? And we'll make sure, if you would talk to Mr. Price and make sure that the appropriate people have a
Sure.
spot on the agenda, we'll certainly include that.
Thank you very much.
And Senator Rayburn, the partnership program has worked in some states, and in other states it hasn't. So the important question is asked, what the participation level is.
And that's what I'm looking at.
Yep.
And, you know, at NCOIL, that we have reports on this. And I think one of the things that we could do is we have this really good opportunity for people to purchase their own coverage and have something in return for that, that therein lies a benefit for the state. Because typically, most people are only going to be on that coverage 3 to 5 years in a nursing home. That's the average. So anyway, thank you very much, Mr. Chairman.
And again, a lot of this is in your appendix, your packet, so you'll have time to go back and look at it and digest, and we can also answer any questions midstream. So now we're starting to get into some of the details on the line items we saw at the department in the DSS system. Dr. Oliver is working with Mark Story. We wanted to make sure for the committee, before we submitted some of these data points, that the department looked at some of the numbers to verify, to make sure if there was an issue, we wanted to raise it, and they verified all of our numbers as far as the budget. So the details here, you can see, you know, hospital services does account for a significant amount, but then we're going to start digging into this in the next future meetings and discussions on some of the claims. Long-term care, you could see the $970 million. Mental health, you should be asking, you know, what's going on in mental health system? Are there ways to curb some of the spending there? We're looking into that for you all. So you start to see some of your high-cost drivers, and you start to see prescription drugs. There's no question in my mind that you could trim some efficiency and greater savings in prescription drugs and give the department some credit on the PBM that they have right now. Seems to be working towards that avenue, and so we're going to continue to discuss with them what are other options and efficiencies to drive savings in the future here in some of these numbers.
As you look at these numbers, particularly on the traditional Medicaid side, do you see any of those that look extraordinarily high or low compared to what you see in other states?
We're going to get to that on
Okay.
comparison to some states.
Okay.
I think, you know, the age, blind, and disabled area is an anomaly, I would say. It's higher than most states
Okay, thank you.
per person cost.
Wait, we got, Senator Irwin, you're recognized for a question.
Quickly,
Do you want me to go
this-
back?
no. This week, we talked about we reviewed an additional $45 million contract for prescription drugs for the medically frail population. It was an additional $45 million grant that was needed and requested. Mark Story can give you details and information on that. I didn't know if that was something that was included in this or not, but it was an addition, and description was given that the medically frail, that's not been put in the private option, that's put in this medically frail category, there's a huge prescription drug cost associated with that population, which required us to apply for another $45 million federal grant for that.
I'd have to talk to Rory Rickert, who I will. I took note
Yeah,
of
if
that,
you-
Senator.
Okay.
And I'm sure he's already looked at it. If you look in your packet, you'll see all the people he's already interviewed, and he's developing some good recommendations for you. So I will make sure he sees that.
Okay, thank you.
So here's one of the areas, the long-term care, to look at. You know, now you're talking about starting to divide up nursing home care, with assisted living, with home and community-based care. You have this continuum of care, which most states look at it that way. And when you start looking at some of these numbers, you've got private skilled nursing, and you also have public skilled nursing. You can see the private skilled nursing is pretty high in terms of the amount versus the others. But again, you want to get down to the per-person cost on average, and you want to also compare that with other states and see where you are, and we've done some of that for you.
What's SNF stand for?
Skilled nursing facility. Assisted living of interest is not a real high-level use in this state compared to other states. We started to talk to the Nursing Home Association and others to figure out what the issue could be there. The payment, I looked at the payment per month payment. It's somewhere in the $2,500 to $2,600 a month area. Your waiver has a limit on the number of assisted living beds. So that could potentially be an issue down the road we want to look at. Again, one waiver, you could have a global waiver without these caps and really start moving in the right direction. I don't know if that's the reason, but this is low penetration of assisted living in this state. And it could be that there's a lot of private, they'll only accept private pay, and there could be placement issues, and we'll dig into that in future meetings. This is your home and community-based program here in this state. And you can see that we totaled it up to about $258 million. And you know you have your nursing home costs and your assisted living. So you can kind of start to see the spread of where you put your dollars in long-term care. I understand your personal care attendant rates are not high. They're in the $9.25 category per hour, I think. I may be incorrect. Director Cloud had given me some numbers yesterday. I think you need to look at capacity in those communities, or maybe in certain regions the issue might be different than other regions. We'll continue to look at that for you in the future. But I think you got to start looking possibly at, making sure you have a good network, and you've got to be able to pay that network if you want to grow that network. So that could be an issue down the road. You obviously had the CFCO issue here. We weren't around. There are other states that have implemented it. Some haven't. We're not talking about CFCO here. You could put into a waiver a focus of community-based care and not have to go down the road of even a CFCO approach, but almost do the same thing, but have a lot more flexibility on your end. We'll give you some thoughts as we move forward. Again, that goes to the whole idea of having flexibility within that negotiation of a waiver. Hospital services. Senator Irwin, I know you asked about hospital services. This line item will take you through every area of hospital services in your budget. Inpatient, outpatient, pediatric care. You start to look at the ambulatory surgical. We are looking at outpatient in the next, I think it's the next one. Yeah, so the next one is outpatient. So look at inpatient and outpatient. And what can you do to leverage some of the opportunities that other states have with the services? We will be looking at the codes as we start to get the claims data, and we'll try to identify where some of the services could be either done at less cost settings, or are there some hospitals that possibly are charging areas of care at a high level, if we can get into that data, versus other hospitals next door that are much less. Just to give you an idea of a barometer, in many states, the variation could be up to 300%. And this is, now there's a per diem payment. The payment basis here is a little different. There's facility charge. We're going to look into all that, but we can't really give you any conclusion without getting the data, and that's what we're waiting for right now.
Where are you getting all this data for these costs from the Medicaid program?
This is from the Medicaid, Department of Human Services has a DSS, a decision support database. It's basically their data warehouse, and most of them, Senator, come from their Medicaid Management Information System, so they're the claims-based system.
Well, for instance, on the slide that you have there, the top line item shows outpatient hospital for 2014, $65 million, and then for 2015, year-to-date, 55 million. Are we really that much higher than we were last year?
And again, those are questions we're going to be asking, but maybe Dr. Oliver has asked that question. Dr. Oliver, did you want to come up and address that? He's really been diving down deep into the weeds in those types of areas. I'm hoping he has that answer.
Thank you for asking.
Push that button.
Yes, it does appear that there's a fairly significant, not only size, but growth rate in hospital services. And a goodly chunk of that, John mentioned early, and that's the so-called non-claims based payments, which are for things like uncompensated care and dish care. But yes, it's large and it's growing faster than almost any other area in Medicaid.
Well, again, if you go down to the bottom and you see 151 million in all of 2014, and we're at 118 million through March, that's 1/3 of the month.
That's 3/4 of the year. It's fiscal year.
Oh, okay, we're doing fiscal years.
Fiscal year.
All right. Does this data include Children's Hospital?
Yes.
Okay.
You want to just stay up here, just in case? And then the third page is details of cost settlements, additional non-claims-based payments, as Dr. Oliver alludes to, and you can start to see the significant dollars that are outside the claims system. And again, we're going to continue to review that and identify how those issues also could be maybe maximized in terms of efficiency. Mental health, the same thing. Looking at the mental health budget, there's in Richard Kellogg, this is one of his expertise or areas, is behavioral health. And Richard is looking at all of these line items. I may want him to say a few words.
Well, the numbers tell a story of what you're spending. They don't tell the story of how the system is working. Basically, it appears you have a fairly high spend in your inpatient psychiatric that Medicaid is paying for. That could be good, or it could be a question of what your capacity is in your state psychiatric hospital, how it's being utilized, what the impact of forensics admissions is on the availability of civil beds within inside of the state hospital, and some other factors. The rehab option, as you can see, is fairly significant and has been growing rather rapidly. And the assessment process in that particular benefit allows any licensed provider to assess an individual and then submit that assessment to essentially a prior authorization process that you've contracted out to Value Options, which I'm meeting with that group tomorrow. There's no standardized assessment, to my knowledge, in the system, so you're going to have a wide variability in what the prior authorization organization, and I need to clarify this, so this remains to be clarified, is seeing. Therefore, it'll be interesting to see what clinical basis they're making judgments on non-standardized assessments on the question of medical necessity, which would be the trigger for approval. The community mental health centers are...
Let me interrupt for just a minute, because we got a question. Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. On the, I want to go back to the hospital question. Are you identifying the contributors to the increased costs? I got the impression that you said that the cost of the hospitalizations was on the rise, or it was trending to show an increase. Did I understand you correctly?
Yes, that's correct.
In a future report, are y'all going to get down into the micromanaging as far as the specifics of what's driving up the cost within the hospital? I mean, we're getting a 100,000-foot view, so are you going to get it down so we can compartmentalize what the main contributors are?
That's the exact objective. Thank you for asking for that.
Okay. And if you were to project it out, because this only shows through March of 15, I guess we could do the math, but is there any spikes in the season, in the year, that would show where we're going to finish up projected at the end of the 15 fiscal year?
There is a really minor spike toward the latter part of the calendar year, so we've already really experienced that in the 2015 data. For rough and dirty purposes of forecasting, I'm just using a straight annualization at this point, but we'll get much more refined at that as we go along.
Okay, thank you, Mr. Chair.
We got another question. Senator King, is that you still in that seat? You're recognized.
Thank you, Mr. Chairman. You mentioned there was a waiver that said limited the number of assisted living.
Yes, yes.
What waiver is that?
I'm going to mention at the end, the final slide with all the list of waivers, if you don't mind, and I can come back to that, or I can go to that slide right now.
Okay, why did you bring that up as significant?
Okay. Whoops. And- Sorry about that.
There you
It's called the Arkansas Living Choices Assisted Living 1915C waiver.
Okay, so you're basically saying if somebody was in an assisted living place, it would be cheaper on the taxpayers than in a nursing facility?
We're going to show you the cost, yes. Yes.
Okay. Well,
Yeah.
why would you limit that number? Have you seen any other states do something like that?
Yes, and some of that is federal CMS requirement. They will ask for a cap, and sometimes it's up to the state, and in some states, they've had waivers without caps. And a lot of it goes down to the negotiation, because you have to show budget neutrality, that you're not going to spend more than you would have without the waiver. And sometimes states are unable to show that, and that's why they put these limits.
Okay. All right. Have you done anything in any other states looking at something similar to what you do in Arkansas?
I actually wrote the waiver in the state of Rhode Island.
Okay.
And it was a global compact waiver with the secretary there. And there are other states that Richard has looked at and has been overseeing the secretary with the same waivers.
Okay. All right. Thank you.
Got another question here from Representative Meeks. You're recognized.
Thank you. The slide that you had just up there had popped up in there. The other one that has, and it had the line adoption and foster care in there on the spending. Can't remember which one it was. It was just, yeah, right there, the adoption. Well, it says adoption and foster care, and it was total spending, I think it was $77 million. You know, on something like that, can you go, because I guess it would be broken down by per member, okay, with the 903. Because that is going to fluctuate depending on how many kids you actually have in foster care and how many kids have actually been adopted. Is that, I mean, is that something that you would be willing to break down? Because I mean, just again, somebody who's been involved in foster care, I would be interested in breaking that down a little bit further to see how many kids we had in foster care in 2007 versus now, and how all of that breaks down as far as our Medicaid spending is actually concerned. Because, you know, there is some probably opportunity there, you know, if we can improve in our foster care system. So,
We will
Thank you.
do that for the next meeting.
thank you, Mr. Chair.
And so this slide is really important, I think, for you all. I don't think, based on the questions I heard the last time about private option, when you were discussing it, I'm not sure you had in your mind, what's the real PMPM for traditional Medicaid? And one of the questions asked of us was, what is that PMPM? So you can see, over the years from 2007 on to 2014, traditional Medicaid PMPM is around $565, versus your private option is somewhere in the 480, 490 area. Now, you would expect, again, these are more expensive populations, but the age, blind, and disabled, which is not in the medically fragile, which is not in private option, is in the Medicaid program. So, but this will give you a good benchmark of where you are and how you can look at other states. And again, it will be helpful down the road when we start identifying alternative solutions. This is costs, again, this is more of a breakdown cost per beneficiary, and this looks at total beneficiary, and you can see the private option, 471. This is third quarter, so it's not the most recent data you've had, and we don't have it right up to today. And you'll see as it compares to the traditional Medicaid as well. And then program costs.
Excuse me, John.
Yes.
Representative Meeks, you're recognized for a question.
My question is on the, again, on the private option, you have
Yes.
$471. That did not, I don't think that included wraparound cost, because my recollection is when you're talking about wraparound cost, it was up around 489, 490. So again, and I don't know what the comparison is, why you only use that 471 number versus the 490 number. Can you maybe explain why you did that?
At this point in the analysis, we're using summarized data. So we're using monthly beneficiaries and monthly expenses. Actually, this is even quarterly. Once we get real live data, we'll actually be able to deal on a per member basis, so we'll have much more accurate information. I would say that at this point, we're just getting sort of decision relevant information, directional information. But you should see by the next and the task force meeting after that, when we have actual claims information, that will get much more accurate.
Yeah, I would appreciate that. And then also too, again, with private option, you have some wraparound costs that might not be directly by the premiums. You know, and again, we've heard from all kinds of news reports and everything that at least that number is 490. But I would like you to take that into consideration as well, that it's not just the premiums, but it's also wraparound costs that are not directly
Yes.
with the premiums.
And
Thank you.
Representative, we received yesterday from Don, Medicaid Director, the wraparound costs for the last few years, last year and this year current.
Okay.
So we now have that data.
Okay, thank you. Thank you, Mr. Chair.
Could I just ask one question on that? The medically frail people, which fall in the private option category, are their average costs depicted in the per monthly costs on your private option line item or in your traditional Medicaid line item? In other words, the medically frail people who are in the private option program, are they included in the 471 or 490, or are they part of the 612?
That's a very astute question. In this particular table, the medically frail are included in the private option numbers. We're teasing those out as quickly as we can. It's just getting the numbers. And just yesterday, we started getting the actual capitated head counts, the head counts of people under the PMPM rates. So we're getting there.
And also, that population, to our surprise, was not as high cost to population that we saw. So we're going to be able to give you more information, but as a team, we begin to talk about that population. And the assessment, we looked at the assessment online and the questions that are asked. And in some cases, those questions, and Richard could probably talk more about the questions, there are folks that are in that category, Representative, that may not be traditionally the fragile type populations you're thinking about. So it may not be as high as the cost that you were thinking about originally, but we're going to get that information.
I would just say briefly, the question, number one, it's a self-assessment, which, we think is ill-advised. It would have been great to have these people enrolled and see their primary care physician and let a physician assess, along with the recipient of the benefit to explain their medical conditions. The assessment mixes some really high-end services that you would probably be asking nursing home residents of, although I don't dispute the fact there may be several people in the community that live under those conditions. But the big story here is assigning people to a medically fragile group on self-assessment. Could have been expedience based on the time, but it would be ill-advised for a lot of different reasons, including possibly safety in some respects. Back to that care coordination issue that John raised, it would have been good to connect these people with a physician as quickly as possible, so if they were medically fragile, they could get the care coordination and the services they need if they assumedly weren't being met because they were uninsured.
And I'm sure you're keeping track of suggestions and recommendations like that to include in your final report about self-assessment versus physician's recommendation and so on. Representative Hammer, and then Senator Bledsoe.
Thank you, Mr. Chair.
Oh, sorry.
Thank you, Mr. Chair. Did you find out why the medically frail were included in the private option? Because unless I'm mistaken, and maybe I'd be corrected by the chairs, but I was thinking the medically frail were never supposed to be included in the private option, and they were to have been separated, and there were some issues when we first started off, but did you kind of see a tapering off of when the medically frail were wrapped into the private option, and is that an ongoing issue still? You said you're sorting them out. Can you speak to that?
Well, they're over income for traditional Medicaid. So that's why they're in there. The interesting thing is how you were able to negotiate. Give your department credit to be able to negotiate with CMS to have those medically fragile populations being paid at 100% federal funds and not being part of the private option. That's a plus.
Okay.
Representative Hammer, before you walk away, let me do this, because this question comes up again and again, and it will come up again and again, because we use the same word to mean two things. So when we say Medicaid, we in our minds think fee for service, but now, since we have the private option, we think of Medicaid as a bucket of money. In reality, we have a private option bucket of money, we have a Medicaid bucket of money, we have a Medicaid fee-for-service, we have a private option insurance. So someone that happens to be in the private option bucket of money who is medically frail will be handled via traditional Medicaid fee-for-service, but they're kept track of in the private option bucket of money, and that would be the reason that the medically frail are included in the 471, even though their services come from fee-for-service traditional Medicaid.
Thank you. Follow-up, Mr. Chair. When it comes to uncompensated care, is going back to a subject this morning about, hospitals picking up the cost of the uncompensated care. Are you tracking that anywhere in this, or is that going to be included in a report in the future so we can factor that in, that if it wasn't, to the 4,000 that were identified and the costs that the providers are having to absorb, are you going to include that in the future, because so that we can add that number to all these other numbers you're presenting to us, because somebody's got to pay for it?
Yes, that's a key part of our analysis, a named part of our analysis in the project. And I was over talking to the UAMS folks this morning about that. The American Hospital Association has done a good study which will allow that us to dig into that. But yes, absolutely, the uncompensated care is right in the middle of our scope.
But that's not reflected in any of these numbers that's in this report, correct?
It's part of what we call non-claims reimbursements.
Is that anywhere in this report?
So that $1 billion of non-claims.
Okay. Okay, thank you.
Senator Bledsoe, you recognize.
Thank you, Mr. Chair. Mr. Stevens, like Representative Collins says, the question about the private option and the medically frail within the private option who are not income eligible for traditional Medicaid keeps coming up. And I think most of the confusion has been alleviated with just the questions that have been answered in the last few minutes. But I want to go over it one more time, because it just seems really hard to, like you said, it's a good thing, but it just seems to be hard to understand how we were able to do that with CMS. But it's my understanding now that in the private option, we have the medically frail. They are put into traditional Medicaid, but they are still, the expenses for them are still being paid 100% from the private option with private insurance. Is that correct?
I would ask Dawn to make sure she clarifies that,
well,
because we just got information from Dawn yesterday,
Well,
and we're analyzing that very question.
is Dawn still here? I looked for her when this came
Yeah, I
up.
see her
Okay,
back
come
there.
on. All right. Okay. Well, we had this just recently, and as Dawn mentioned in our last health meeting, Public Health, Welfare, and Labor Committee meeting, that's what she said, but we continue to become confused. Now, where will those people be listed? You mentioned in the 476, or tell me where they'll be listed in terms of the expense. They won't be included in the expense of the private option. Is that correct?
That's my understanding. Dawn, is that correct?
Don, would you come down? Because
Yeah.
I thought I understood, but now I'm confused too.
And we're just getting this information from the department on those
Okay.
medically fragile population.
And I think just the other day, Dawn and I were kind of laughing about this because it seems as if misinformation continues to swirl around this particular question.
You're recognized, Don.
Thank you. Yes, as we discussed at the last meeting, all of the expenditures associated with the medically frail are covered at 100% of the cost because they are considered part of the expansion population. They are served in the traditional Medicaid program, but their costs are all covered at 100%.
But where are the costs listed? Is it listed under the traditional Medicaid group, or is it listed under the private option?
I don't want to speak for Dr. Oliver's analysis, so I'll defer to him on that. I would say when we characterize them within Medicaid, we typically show them within private option in terms of you have private option expenditures such as qualified health plans, the premiums, the wraparound costs, and then we have the medically frail. But I think that's part of, as we look at the medically frail in general, kind of how best we want to show them as we go forward. But I'll defer to Dr. Oliver in terms of this report.
In this particular report, we've, on this particular page, we've included the medically frail in the private option because a lot of the focus has been based on state reimbursement, and it's the 100% reimbursement. It just made the accounting easier. We now have the data to break it apart more clearly, and next time you talk to us, we'll have it broken into 3 buckets. Traditional Medicaid, the medically frail, which is traditional Medicaid, but it's that unique group that gets 100% reimbursement, and then those covered by carriers.
All right, well, would that not skew the cost of the private option, though, if you do that? In other words, if we say what is the total, what will that cost us? Would that not skew that?
I'll answer that,
All
because
right.
this is the very question that I've asked Dawn. So we're going to get this information for you, because I think this is, I want to make sure I clear where you're going, because I think it's where I wanted to go when I asked Dawn. What I want to know is when they have a cap, that they set a cap in the waiver and say that the private option spending is going to be only at this level. Does that include the medically frail dollars, or are those dollars taken out and put into the normal Medicaid program under the dollars, so that when CMS looks at this, and you, as policymakers, you will know, did you really reach the cap or not? That's
Exactly.
And I haven't received that full information yet.
That's exactly what I wanted to know.
Don,
Thank
do you want to comment on that?
Certainly. The short answer is that when you look at the waiver, and some of this gets fairly technical, but within the waiver there is the budget neutrality in terms of basically how much are we spending and what's included in that. As the terms and conditions were originally negotiated with CMS, the medically frail are not included within that cap in terms of for the waiver neutrality purposes. So that is separate. But as I said, because they are considered part of the new group, the new eligibles, we are able to pay out their expenditures at 100%. So it does get to be a little bit confusing, but it's important to understand the differences in terms of where the funding lies, and then also how we account for them in the program.
But to me, one of the most confusing part is that these people do not qualify for traditional Medicaid, and yet, we are putting them in, and to me, it just skews everything. But you want to comment on that?
Certainly, I'll be happy to start, and others may want to join in. I think early on when we started the program, the idea was that we didn't know exactly how expensive or what kind of health needs these individuals were going to have. I think as as Mr. Stephen had testified, I think they're actually a lot less expensive than we had originally thought and even projected in our estimations. And I think at the time, because of the concerns about wanting to make sure that we were only putting, fairly healthy people within the marketplace in order to get, good competitive rates from the carriers, the decision was made to keep that population outside of the marketplace. And so that really was a decision early on. I think that's something, certainly as we look at whatever, options may come in the future, where we may best want to serve those medically frail individuals, knowing to your point that today, they might not be otherwise eligible for traditional Medicaid, but if you look at them within 6 months from now, they actually might be due to their health status or their health needs. But that's definitely one of the things I think that we're going to look at.
All right, thank you, and I
Could-
appreciate.
Could I, John, just, if we just go back to your page 11, I think your page 11 data breakout gives a little bit more insight into the impact that the medically frail inside the private option has on a cost structure. Because in there you've got a side-by-side between traditional Medicaid and private option payments. And if you look down the column, you'll see private option premiums. There's nothing in traditional Medicaid. There's $280 million in the private option. Then if you look at the grand total for the private option, it's $367 million. All those numbers above the premiums are a good ballpark as to some of the other costs that are being spent on these medical frail people that do not have health insurance premiums being spent for them, and all of it showing up in the private option expense category, not traditional Medicaid.
Yeah, and if I can just clarify, because I think the Senator's point is very well taken, so I want to make sure we come back to you and we're able to be clear, because one thing I really want to get to the level of where the department can give us the information is, okay, if it is included in the traditional Medicaid, let's assume that's the case. Obviously, that's what we're showing you. But if you extract that out and add that to your private option cost today on a PMPM, how much more does that take your true private option costs? Where does it put the cost? And I want to be able to get that for the committee, because then you're going to be looking at, this is what really your private cost PMPM is. And so we're going to be able to have that for the next meeting, and those are questions that Dawn and I have been talking about.
Well, thank you. That's exactly what I wanted to know. And I must commend Dawn. She's always so available and so willing to talk. And after we talked, I think I really understand it. And then I'll hear something like this, and I'll think, now, wait a minute. So thank you very much. And Dawn, again, thank you.
Thank you, Senator.
Before you leave, though, I heard one thing there that I did not understand, and I want to make sure that it's accurate. This frail population that we are putting into basically fee-for-service Medicaid, those dollars are not going through the insurance companies, are they? Aren't they going directly from the federal government to DHS to the providers?
You're correct.
Okay, so again, the only thing that the insurance companies are dealing with are those that are not medically frail, that they're deemed eligible and receiving the premiums for.
Yes, sir.
And again, the other thing that I did not know until today, which was interesting to me, is I did not know that the waiver allowed us to not count that medically frail population when you're determining budget neutrality. So I guess my question there is that obviously drives there's a perverse incentive to push more people into that population, or to make sure that the high-cost people are into that population to keep us under the cap.
I think at the time, and I wasn't involved, so I don't have all the intimate details, but I think at the time the idea was that since we were basically testing whether or not a like population could be served within the private sector through carriers, basically to compare apples to apples in terms of if you took this healthy population and served them in Medicaid versus in the marketplace, what would you compare them to? And the idea that those individuals who are medically frail wouldn't be a good cohort group, if you will, for comparison, because they would not typically be the same population you'd see in the private market.
And that is if that is the case, that's one thing that I would like to see, the Stevens Group provide us, is if that is the intent here, is to compare, a healthy population in that poverty band with a healthy population above that.
Mm-hmm.
How is our per person per month cost comparing to the private sector? I think that's going to be important information to have. I know Mr. Kocher has a question, and Senator King has a question.
Yeah, and again, now I want to make sure that I understand what I thought I understood a moment ago. On 19, you've got $471 per month per person for the private option. My understanding is that includes the insurance premiums on individuals which are not deemed medically frail. That includes the traditional fee for service costs of private option eligible people who are deemed medically frail. All that money added together, divided by the number of people, and that's $471 per person. So it includes the medically frail and the insurance population that are in the private option. Is that correct?
That's correct.
So the bottom line is, within the private option, both the medically frail and the healthy and the costs associated with both groups are used in calculating that 471 number. Now, whether it includes the wraparound, so make it 490, is still up for debate. But it does not exclude the medically frail people. That's what I just want to make sure that I understand properly.
That's correct.
And Don, you agree with that as well, that our total cost per member per month, when we say 471, even though we calculate the cap number differently, that is including the medically frail?
Based on Dr. Oliver's analysis, yes. I mean, that's typically how we frame them, but I'm always careful to speak for somebody else's reports or analysis.
Okay, when we see the numbers that you all report in the paper that shows
Right.
that we've had a $2 increase and we're $5 below the cap or what it is, are you all including the medically frail in those numbers?
I believe so. Suzanne, is that, they're not, okay, they're not. So I think that is an important thing that we'll need to look at in terms of, for our numbers, because it typically is the qualified health plans in terms of the money that's going to the carriers for everyone's care. It is also then the cost savings reconciliation in terms of what we have to make up in the difference, and then there are the wraparound costs. So we probably just need to make sure we're looking at apples to apples in the medically frail versus the QHP population.
That'd be good. Okay. Senator King, you have a question?
Well, you just said exactly, because I emailed them, but no, that 471 did not include the medically frail. And that leads to my question, because I've tried to get the numbers. What does it cost per month or per year what is it costing us for those medically frail people? You guys have never given me that number.
Well, I know we talked a little bit at the last meeting about what those costs are. I think part of it has been, now that we are in the second year, we had to wait for the full first year of claims to run out to be able to look at some of that information. So that's something we're looking at now. We obviously want to make sure that we're running that analysis in the same way that's consistent with how the Stevens group would look at that. So. And
let me just say, again, I said at the beginning of the meeting, the July meeting, one of the subjects is going to be an analysis of the cost, because you all haven't even gotten the data from the carriers yet.
And we also have asked that medically frail question too, and we're still waiting, and we haven't looked at the claims data. So the one thing, Don's been really helpful, it's just that maybe even the people we're asking are not telling us accurately what it is. I just want to make sure the next time we meet and we work with Don, we will get the question answered as far as whether the medically frail are in or not and how much it is. Because my concern, just like I think where the committee's going, is what is the true cost of the private option? And that's one thing that we're going to find out for you. And we're giving you the best we can right now.
Well, Mr. Stephen, that's been something when I was chair of audit, we tried to find out, and we never could find out. And I mean, this program's been in effect now since January of last year, and we still don't know what the cost is of covering these medically frail people. So
the best thing I can tell you is we've requested the claims data, and it's going to be given to us by the department, and we're going to have the actual data now that we can analyze.
does the federal government not have a backup or something that they know that is what it would cost? I mean, do you not have a source at the federal government level, since they're paying for this, or we're paying for it through
All right,
them?
again, I don't want to spend a lot of time going through the cost of private options, since that's going to be an entire meeting dedicated to that, and they just don't have the data yet. I've been asking too, Senator King.
Oh, they have the data.
We've got the cost from what the federal government's paying, but we don't have the cost of what claims are being paid.
Well, DHS has the data.
Do you have another question? Representative Meeks.
Thank you. And this is, Don, I guess it's probably directed at you, since you're the one that made the statement, and a clarification response. Because you said that whenever they were trying to figure out a healthy population to healthy population, basically comparing to apples to apples. And you said that that's one of the reasons why they took the medically frail out and separately. There are people on private insurance, there's a large group of people on private insurance that have medical issues. So I don't know how you would respond to that, or, because you weren't a part of the details, I guess, but I just, when you're comparing apples to apples, you have a lot of people who are unhealthy that have private insurance over here, and that's where, you know, again, insurance companies are groping with their costs as well. And so could you clarify or respond to that? Again, I understand the reason why you've got the medically frail over here, but if you're going to compare apples to apples, you're still going to have some of those medically high usage folks. And so I don't know that we're going to get a good comparison between the two.
It's an excellent question. I would say that's one of the things we're trying to evaluate now, because I think, as you heard a little bit in some of the earlier presentation, the way that somebody is defined as medically frail is basically they have to self-attest. I mean, we're not going in and, you know, trying to identify them on our own. They have to come to us and say they have significant issues and take the screener, and then we look at whether or not that meets the criteria. As I mentioned, you know, one of the things we have seen is that the costs do appear to be lower for that group than we had projected. So, I mean, one thing we might want to look at is whether or not, you know, what we're seeing in terms of the experience of the medically frail is what had been projected. But I think also, to your point of whether those people, potentially the health conditions they have today, how they compare to the people we're seeing inside of the qualified health plans. Because, I mean, it's important that, you know, I mean, like anybody, you know, in private insurance today, I mean, people have varying ranges of medical needs. Really, the big issue for having the medically frail population set aside is that for individuals who really need services that, you know, traditionally the private carriers have not offered, things like you know, long-term service support, somebody who needs personal care, somebody who needs assistance, you know, above and beyond what you would normally get through a private carrier. But as I mentioned, that's something we're looking at. We want to evaluate both what we're seeing in the medically frail as well as what we see through the carriers inside of the qualified health plans, and get a true sense of what those populations look like when you compare them against one another.
I'm going to follow up question, Mr. Chair.
Okay.
And do you shift people in between the medically frail? Like if you have a carrier that comes and says, hey, we've got somebody that's really using our system a lot higher than what we thought, do you then shift them over to medically frail? On the flip side, do you have somebody that you put in medically frail and they're using the system, but they're not using it maybe as much as you thought, and said, well, okay, well, maybe they're better over here in this other area? Are you doing that shifting back and forth?
Right, so we do have a process with the carriers. We call it a mid-year transition process, but really it can occur at any point throughout the year. Basically, where they could come to us and say, we believe that this particular member could best be served inside traditional Medicaid because of their health needs. And we work through them with that process. We evaluate their medical records. We work with the carriers to understand more about their health needs, and then make a determination whether or not they really could be served best on the Medicaid, traditional Medicaid side of the house. As to the other part of your question, I mean, that's something we're looking at now. I think now, since we're, you know, since we've gotten enough claims that have run out in the program to get a sense of whether or not some of these folks, like how often they're using the coverage, what kinds of services they need. You know, we provided a little bit of that at the last meeting in terms of, as you saw, a lot of things that overlap with the traditional Medicaid population, but that's something we're looking at. But at this point, we have not started moving anybody back from medically frail into the QHPs, but it's definitely something we need to look at.
But you have moved people from the QHPs into medically frail?
We had a few requests last year. At that point in time, we weren't able to get some of the issues resolved around some of their health needs to determine if that was going to be an issue. At this point, we're still looking at some of those with the carriers, but at this point, we haven't actually moved anybody that didn't go through the original medically frail determination process.
Okay, thank you, Mr. Chair.
Okay, Senator Rice, you're recognized, and Dr. Bledsoe.
Just quickly, and I'm sorry I didn't get your name, sitting next to Mr. Stephen. Appreciate your input and would welcome any other input from the last few questions that we've had. Reading body language, I think you've got some analysis that you might be able to share. Please.
I'm sorry, what was the question?
You just seem to have some analysis in the question from Senator King, and I would welcome any input that you had on what we've been discussing the last couple of segments. Did I misread you? Okay. I thought you had some things you wanted to share, and I wanted to give you opportunity to do it.
Thank you.
If you don't, thank you, Mr. Chair.
And before I go to Dr. Bledsoe, I skipped over Representative Hammer, so let me get him, and then we'll press on. Push the green button.
Thank you, Mr. Chair. Don, early on when all this started with private option, I remember the insurance companies kind of rose up because they were getting some medically frail people put into their policies. I don't know if you were here or privileged to that when that went on, but they were coming to us and saying, hey, they're pushing medically frail onto us and we're having to pick up the cost of it and everything. Two things. I wonder, the arrangement that was worked out with CMS that you referenced a while ago, Mr. Stevens, was that part of the intervention so that there could be that arrangement made where the insurance companies wouldn't have to pick up the medically frail? And I remember there was a process where they started getting shifted back into the traditional Medicaid was the explanation that was given to us. So I'm trying to grasp how it is we're paying for the medically frail under the private option, but early on the insurance companies were rising up and saying, hey, we shouldn't be taking these folks because they belong in traditional Medicaid. So do you remember any of that, or do you have anything to say on that one?
I can offer some comments, then I'll defer to Mr. Steven. I think in terms of, as we talked about in the last question, carriers at any point can come to us and say, we think that we need to move people from the QHPs into medically frail. As I mentioned, we had approximately, I think, 30 last year that carriers had brought to us. As I mentioned, we're still in the process of reviewing some of those. We've not moved anybody at this point in time. I think we're still looking at their health care needs. But, I think at this point, the idea is still to have that doorway open, but the idea that if somebody really can best be served inside a qualified health plan, we want to support that. But obviously, we'll continue to work with the carriers and see if there are people who may need to be served inside of Medicaid.
All right, and then Mr. Stevens, when it comes to the term medically frail, that was one thing early on in the private option debate that, took place at the beginning. There was question as to who qualified to be medically frail. So when this term medically frail is being tossed around, are we in alignment with what other states are doing? Is that a federally passed down definition, or do we as a state have the latitude to say this person is defined medically frail by this standard?
It's a state standard that you decided under your waiver and your standard terms and conditions. So it's a state issue.
How do we compare to other states and their definition of medically frail? Are we a little more lenient, or are we a little harder, or where are we in the 1 to 50 range?
I don't know the answer as far as expansion population. I can find that out for you, but I will tell you that just my feeling about the waiver negotiation process is someone on your team, on your side, going into Baltimore with CMS, was looking at those costs, was looking at that population, and was pretty smart to say, you know what, we want to exempt these from the traditional. We have an assessment process we're going to build into our standard terms and conditions. We're going to take care of that population, and we're going to move them into the traditional Medicaid, but we want 100% federal dollars for this because we're going to keep them out of high-cost settings. Now, they could have said, we're going to use episodes of care, we're going to use payment improvement, we're going to, and convince them, Representative, to be able to say, okay, we're going to pay for it at 100% cost. I don't know, I wasn't here, so I'll dig into that with Dawn and her team. I don't think Dawn negotiated the waiver, but what I'm saying is we need to keep digging more and figure out for you what's going on. And then when we get the claims, to me the important thing is when Dr. Oliver and his team look at the claims, we're going to be able to come back to you and say, this is what this population's costing you.
Well, and that's all going to be driven by the medically frail definition, is it not? Or is that not going to be a major contributor to that cost?
The good news, and Dawn, correct me if I'm wrong, the good news is they have these coded in the claims system. So we'll know exactly where they are in the system when we get the data.
Okay, and that would be coming in a report in the future then?
Yes, you'll be getting that. We hope to get the data very soon.
All right, thank you.
Dr. Bledsoe.
Thanks, Mr. Chairman. Just a quick question for Mr. Stevens. I went back through the Alexander report a few weeks ago, and one of the things that was recommended in that report was that a dashboard be set up so that elected officials could log on and in real time track where the money's coming from, where the money's going for various programs that we had in state government. As far as I know, that was never attempted in our state, although it was recommended. Have you ever seen that applied in other states? Do you think that that's a viable option? Because it seems like a lot of the questions we're getting from these folks here on the task force is a frustration at not being able to access and not understanding where the money's coming from and going to, and it doesn't seem like they're able to get the information they need as quickly as they want. So a dashboard like that, if it was possible, would be very great to have.
It is a major discussion among states in the country. It is one that legislators need quick information and rely on the departments to come and give them what they have in their system. And legislators are smart enough to ask the right questions, but they need a dashboard. In many of the finance committees as well, and some of the budget discussions in the states are actually putting money aside for a Cognos or other type system to come into the state so that you have real-time access to what's going on in terms of decisions so that you can appropriate money in a sound manner. So your question is not, I don't know of a state that actually has done it, but I know that there's discussion in Texas, there's discussion in Maine, and there's discussion in Pennsylvania right now ongoing about that issue.
I just think, you know, when you look at the amount of money that's flowing through these different programs and the fact that the people who are supposed to be keeping these programs accountable don't have access to the information, I mean, it just seems like a big problem, and one that with all the sophistication that we have of our IT programs available to us, it should be solvable. But
If I may, though, and Dr. Oliver is my team expert on the data analysis, I can tell you that he felt very comfortable where you are today versus where you were a few months back, because they have just now been able to put online a data warehouse that actually is going to have at least 9 years of data and other historical, so you can actually start really modeling and looking at information. I'll let him answer that, but I think you're in a better position today.
Can I tell them about it?
Yeah, it's fine, but I mean, it's live now, but it's not necessarily on the website.
It's still beta, right? But I would like to just sort of do a shout out to Don's group, particularly Mark Story, who has worked diligently to try to pull sense together. I don't know if you're an accountant, but I am, and working with budget reports is much worse than a root canal. But what Mark is working toward developing, I think, aligns with what you're saying. It's still in a beta version, but he's got if you're familiar with the term, a cube, where you can look at recipients or beneficiaries, and you can look at different years, and you can look at different months, and cut it many different ways. So it's not ready for prime time yet. I don't know when it would be ready for legislators, but I'm saying that they will have far superior tools for answering your questions than they've had in the past.
fantastic. And in theory, once this goes live, will this be accessible to the elected officials who are on the various committees, or any idea?
I think that's definitely something we can look at. I mean, at this point, I think as Dr. Oliver said, we're still trying to, make sure we've kind of worked all the bugs out of it, because it does really get down to the level of looking at, per person costs across different eligibility groups, which is something we didn't have the capacity to do in the past. So it's something we want to do. I don't want to commit to, exactly when we'll have it ready or when we'll be able to make that available to others. But we are excited about having the capacity and appreciate Dr. Oliver's comments.
Great, thank you very much.
All right, John, I think we're done with questions on this, if you want to continue.
Yes, I think we've covered most of this. Okay, so the trends, here's what we talked about earlier. You look at your year 2014-15, and this is looking for in your aggregate claims. So we haven't gone and looked specifically yet at the claims, but not bad, 2.2% increase in 14, and 15 is trending, could potentially even be lower, but right around, we think it's still going to come in around that 2% growth, which again, is not bad for your state. And in future meetings, I'm hoping that our team can come back and try to give you an idea, working with the department, of what are some of the areas that we have validated that we believe are accounting for some of that growth, in a smaller growth. top growth areas in traditional Medicaid by cost categories. Again, we've covered a lot of this. But the difference here is you're actually starting to see what the percentage growth is in each of these individual areas, the years 2007 to 14, and then 2010 to 14, and then the current past couple years. And you're going to get a sense to see, okay, what are the particular areas in the line items of the budget that are growing high, and where are the areas that are growing low? And as you begin to make your decisions down the road, you may even want to put more emphasis on certain categories as you design whatever alternative solution you have.
John,
Yes, Representative.
just in glancing through those categories, everything in the most recent period is down except for one category, prescription drugs. Is that specific to Arkansas, or do you think that's happening nationally?
That's happening nationally. There's generics that have gone up. There's some new drugs that have come off that are actually going with higher patent longer patent periods, and you're going to start seeing states across the country, because I've been hearing it, start to look at additional aggressive pharmacy savings. And we're going to be able to capitalize, Representative, on some of those issues.
All right, thank you. Senator Chesterfield, you have a question? You're recognized for a question.
Thank you. I'm looking at DD.
Yes.
4.2%.
Yes.
Is that developmental disabilities or?
Yes, it is, Senator, developmental, and I apologize for using the two letters, so.
Just give me a glossary the next
Yes,
time.
you're getting it. It's coming.
And could you tell me what other is that is decreased by the 5.5?
Doctor?
I just took all the small items. I mean, I
okay.
could give you the detail, but it's just the small items where, when you start seeing big negative numbers, negative growth rates, it draws your attention, and I wanted to steer you away.
It's a
'cause they're so
minimus
small numbers.
number, is it?
Yeah.
All right, thank you.
And Representative, I'm glad Senator Chesterfield brought that up, because the prescription drugs is not the only growth area. And a lot of this is because of institutional high-cost care. And that's something that down the road that we're going to want to talk to you all about, because we believe that you could potentially have additional efficiency savings in looking at that area, but also bringing good quality of care. Because anything that we give you for recommendation, we want to make sure has been looked at, tested, and scientifically vetted, available, and promotes quality as well. Again, this is going over some of the growth areas, specifically adding some of the, like, I think more specific claims in the beneficiary aid category. The next one is the projected state share. Someone on the committee had asked, what's the state share versus the federal share? This slide is going to show you, and if you look at the private option, you start to see 2017, 18, and based upon the percentage of match, and we've estimated those, which projected those estimates for you, but we're going to get better estimates as we get going. Again, the private option data, we're still getting some of that coming to us now. But this will give you an idea going forward. Someone had asked on the committee to give some estimates on future projections. And the next few slides, you're going to see what we're trying to do here is just think of it as a sample right now. To show you the capabilities of some of the things we're going to look at, you tell us that you think, or we look at a hospital area services, we think it might grow an average of 3% over the next 5 years. We could end up modeling that for you, and you'll see in the next few slides as well. So this is how you also arrive at budget neutrality. And you're going to see in these next enrollment history we're looking at now.
So if I look at your chart 24 and I go out to the year 2020, and I realize this is not a hard, firm, fast, guaranteed prediction,
correct.
but just your initial blush is you'd be forecasting the state would be spending somewhere between $54 million and $74 million on the private option, and somewhere between $2 billion and $2.9 billion on traditional Medicare. Is that it? And I realize it's not
Yes,
a guarantee,
some of those,
it's just
yes.
a rough forecast.
Yes. And the slides, just so you know, at lunchtime, we went back and we revised some of these estimates based on some information that's coming in. And again, we're trying to get you the most updated, but I think that was Representative Meek's question, I bet.
Representative Meeks, you're recognized for a question.
Yeah, that's what I was saying, because in yours, it's, in 2019, the high scenario says 42 and 74, but on your chart, unless I need glasses, it looks like 132 million and 237 million. So that is quite a huge difference between what we have on our paper here and what you have up there.
Dr. Oliver?
I wish I could say that was a sophisticated change in assumption, but I'll fess up, it was an error.
Okay, so your numbers that are up there, that 132 or 152 and 237 is what it should be?
Yes.
Okay, thank you.
And we're going to send this electronically to the committee and to Phil, so he can get it to the entire committee. And then, we talked about this top growth areas. Wait a second. The enrollment history. I think this is important for you to look at. Slow growth. You've seen over the past few years even, slower growth than even some of the other states we've looked at. But it's going to continue to go up in the elder population as we go forward, and we're going to be able to get you some thoughts modeling some of those numbers going forward. But here you can look at the different areas and see the population growth that is factual from 06 to 14, and those are the numbers that come right off the state's budgetary information. Actually, caseload information. Any questions on this?
Senator Chesterfield, you recognized for a question.
Thank you, Mr. Chair, and I shall be brief. All of these individuals who will be coming of age in 2011, say, or came in 2006, it was pre-access to universal health care.
That's correct. That's correct, Senator.
Would it be reasonable to believe then, if we have increased the number of individuals who have had access to preventive care, that the numbers could conceivably come down?
I mean, if you look at your Medicaid numbers, let's look at the expansion population not included.
Mm-hmm.
The Medicaid numbers alone are going up, but at a slow pace.
Okay.
What I think you're going to see in the next few years, and we're going to send those models to you, is on the aged area, there's going to be more significant increase in the Medicaid, traditional Medicaid numbers.
And why would that be?
Because there's aging population, and there's more that are income.
Well, let me explain that.
Yes.
I understand that the older we get, the more, God, let me not tell you,
Yes.
I know. But many of us have also had access to health care before. So being old and disabled are not just necessarily the same thing, are they?
No, but the
Usually
category.
go hand in hand.
The category is Medicaid eligibility. And if you look at the growth in that population, there's going to be necessary growth in the Medicaid aged category for eligibility, financial and both programmatic.
Okay, well, what about the medically needy disabled? Are the disabilities a result of those things that are nature, or are they due to a lack of access which has created some of the disabilities?
It could be both, Senator. It could be both.
All right, and I'm not going to beat it to death, Mr. Chair, because I get the eye from behind. Thank you.
You're good, ma'am.
Enrollment projections, here's some of the questions that you were asking, some of these answers, just looking at population growth. And we want to ask, Representative Chair, we want to ask the state to be able to give us some of their budget population information they use here for the state, and we'll try to use that going forward. Because I'm sure you have folks that have projected population numbers going out a number of years here, and we want to use those same numbers. So it's likely that traditional Medicaid enrollment will continue to increase about the rate of the state population. While private option continues to grow, it's likely that we see a plateau in 2015, and it could be based on the population growth age area. So, you know, we say it's prudent to project all categories of beneficiaries at 0.5%, but again, we'll come in with some really good numbers for you after we look at what your state relies on. But that's what you want to use as you begin to model going forward. These are slides now 27 on. We're going to do some modeling. Someone on the task force asked us a question. What is it going to be like 10 years from now? How much? We don't have all the data and the information, so we can't give that to you right now. What we wanted to show you is as we begin to think about a waiver, as you begin to think about an alternative solution, you have to do these types of projections for CMS, and that's what you put in your waivers. What would happen with the waiver and what would happen without the waiver. And they're usually based on 5 years. It's a contract, and these projections become really important. So whoever asked this question was the right question. But we don't want you to get, stuck on these numbers right now, because we got to make sure we get the right projection in there that you all are satisfied with going forward. But if you see, you can basically see where the program's going on normal growth. And then the next two slides, again, we changed some of these slide numbers because we based on 2014. So I'm going to send this to you electronically because over the lunch hour we'd started to work on we had received some information on private option that I looked at. So Dr. Oliver made some corrections. At the end of the day, all I want you to see in the next two slides are just thinking about how we're going to model going forward to help you. And Senator, I'd look at the slide on the TV monitor, because this is the one you're going to get electronically. And what you'll see is take those growth estimates that we've looked at historically and begin to project out where is the cost going to go. And you start to say, wow, this is going to cost the taxpayers a lot going forward. And you need to look at some of these areas because you can control some of this growth. And other states have, and we're going to help you to identify where you want to start controlling some of the growth. But this is what you're going to need to do in any type of waiver, and identify what you have to have budget certainty, and you have to have what's called budget neutrality when you negotiate a waiver. It cannot cost you more than what it would be without the waiver. Is everybody understanding that? Because so when you, Senator, decide if you want, a 1332 waiver may not have the exact budget neutrality, because as you know, Dr. Chen said it has to meet, it can't have budget deficit criteria. I don't know what they're going to determine to be budget deficit. Can't add more to the deficit. At the end of the day, it's OMB, and they're going to make the decisions. The issue that isn't in 1115 is, whatever you come to as a negotiation for a waiver, it cannot cost the state of Arkansas in those 5 years more than what it would have cost had you not had the waiver at all and just continued the same program on idle. And so what's important for us to show you is, what does idle look like? We're not sure this is exactly what CMS would agree with. But we want to show you that we could do a lot of modeling for you if we come out and look at those claims and figure the historical and now start to really get more precise. This is what your team at the state is going to need when they start to have those discussions. Does that help? Because this becomes very important to have.
Representative Meeks, you're recognized for a question.
Thank you, Mr. Chair. This may be something that, we may need to expand on in a future meeting or whatever. But, we're using our data. Does CMS or whoever it is, do they go to CBO or some other group and I guess look at our numbers to make sure that what we're modeling they actually agree with? So how does all that match up? Because we could come up and say, look, because we're pulling this group out, we're doing this, that, and the other, like we do with private option, we have budget neutral, and then they comes back and say, well, we don't like the way that you model the data. And so can you kind of go into that whole process?
So you have your MMIS system, your Medicaid Management Information System. The department is required to send reports every quarter to CMS to get the draw down federal funds. And so all the numbers for each of these line items CMS has. The question is, though, Representative, what is it going to look like going forward? And that's a very difficult question. And that's something that we'll continue to work with you on. So you look at historical data. To understand the waiver process, CMS has their own database based on your claims. They actually have auditors that come in as well. When you negotiate a waiver with CMS, now you got to take that waiver and bring it over to OMB. And OMB may have different numbers than CMS. And it becomes very complicated, but the beginning discussion is our state of Arkansas, DHS, and here's the Medicaid information system we have, and here's what Dawn and her team have projected going forward. Here's what we think is going to happen with private option, what we think is going to happen if we continue the same way. Here's what we think we can do by changing it. And this is why some states are saying a global type waiver with just a 5-year amount to do a lot within. And if they are able to give you a projected growth, for example, in Rhode Island, they were able to give, when I negotiated, a 7.5% growth per year for 5 years. At the end of the day, in that 5-year period, Rhode Island was spending around 3.5%, 4%. And there was a lot of money left over for a small state. And then the question becomes, what are they going to let you do with that money? And all that has to be negotiated. And that's why all of this modeling is going to be incredibly valuable down the road, post-October, when you want whatever alternative you all come up with to help the department. And you're going to be much more knowledgeable now on what some of these numbers are.
Thank you, Mr. Chair.
Okay?
Representative Hammer, you're recognized for a question.
Thank you. Mr. Stevens, on page 15 where it talks about the expenditure forecast detail, are those numbers tied in any way to what's on page 10 as far as the Medicaid cost per beneficiary? Are those, the expenditure forecast or any of the projected forecasts, are they based on number 19 on page 10?
I'm not following. Which, are you looking at, Representative, the update?
Well, I'm looking on page 15 of your handout, which would be slide number 29.
Okay, that's what I needed. Which again, we worked some of these numbers over the lunch period, so look at the screen if you can. But go ahead. What was the question?
Okay. On page 10, slide 19, where it says the Medicaid cost per beneficiary, and I think it's at the very first, it's got the private option cost, and the numbers are low on the front end, which would have been the startup of the private option. And one thing that was heavily debated here was whether we should advertise, not advertise, messaging to get, people to come in and enroll and everything. So almost for the first 6 months of the program, you'd have to question how many people were actually enrolled and, the startup costs, the uptick costs. So I'm wondering, when it comes to the projections that you're giving us, did you discount maybe the first 6 months, or did you just go from ground zero? And I wonder how that's going to impact the projections into the future, and how far out it'll go before we get the true numbers.
Yeah, well, we've actually looked pretty carefully at that and have it quarter by quarter through 2014 and 2015. So we're very, very attuned to the ramp up. And it was a fast ramp up, but over about a 7-quarter period. But in the projection on panel 28 and 29, what we did is you see actual 2014 numbers there. To get 2015 numbers, for the private option component, we took actual 2015 numbers at the 9th month, at the end of the 3rd quarter, and annualized that number to accommodate exactly what you're asking about. The rest of the numbers in the 2009 column, the fee-for-service numbers, are extended at the growth rate shown there, which is the growth rate between 2013 and 2014. And I've gone over with Mark Story, and based on now 49 weeks of data, it looks like that's a good approximation of the growth rate in 2015 as well.
Okay, so the first 6 months have pretty well filtered in, and we're getting a true, these projections are the true numbers considering startup and everything.
Based on 3rd quarter of 2015 and annualized, yeah.
Okay, and when it comes to the cost to the state, then you've also factored in that as a state, we've got to start picking up more of the cost from the federal level as far as the match rate dropping down, because it had a higher federal match rate at the start, but after I think 2 or 3 years, it's dropped down to where we as a state have to start assuming more cost.
Yeah, on the screen, not on the older version that you have in paper form, but on the screen. And when you get the newer electronic version, I've actually anticipated that question by putting the roll-in rate of state match on the private option. There on that bottom row up on the screen, you'll see that in 2014, there's a 0% match. And by the time you get to 2021, you've got a full 10% match.
Okay, very good. Thank you.
I hope this has been helpful because we may not be as accurate right now because we're still waiting for the claims, the actual claims, but it gives you the idea that we're going to be coming in with numbers that you're going to be able to look at to help the department when they begin their modeling post-October 1 as well. This is the nursing home versus assisted living slide on page 30. I wanted to make sure we highlighted it because it was one of your questions again. This isn't just, we wanted to show you this because we think it's important. Someone on the task force in their question asked the difference between the nursing home and the assisted living expenses, spending. So as you see, the private skilled nursing facility, just looking at the last, in September's amount, we were able to get down to a per day cost of $140 versus the public skilled nursing costs, you can see, substantially high. And then you look at your assisted living at $63 per day, and you start to get to see the difference in the amounts. And this was all based on 2014, and some of those may have gone up based on rate changes. But what I want you to also remember is the 140-day rate for the nursing home does not include the bed assessment, and it does not include the amount from the Social Security payment that the individual makes to the nursing home as well. So there's other components in there as well. And so we can get you those. I'm working with Director Cloud trying to get you that real picture as we move forward. But this will give you a really good idea of the differences in the rates, which is what one of the task force members asked. This is a really important slide, we think. 31. So somebody on the task force asked, can you show us where we stand with regard to other states? I think that that's the right question to be thinking. Arkansas may be a lot different than Texas, than Mississippi, than other states, even your neighbor states. But you want to be able to see where you compare per resident costs. And I think that's important down the road. So this slide, and Richard has really done a lot of work digging into research that's done all over the country. This research here comes from Truven Health Analytics. We have looked at this, but understand that it does not 100% match with everything in your MMIS system. We don't know here exactly what data Truven used in these other states. But we know that every state looks at Truven's data, and this is also Kaiser as well. It's going to give you a benchmark. And what we're going to do is also contact some of these states personally to see if we can actually get their budget data and start making those comparisons for you. So when you start looking at these states, you get a good look at your expense per resident is much higher, and your rank nationally with Truven is 11th highest Medicaid state in the country. 11th. Now, that's 2012, and I will preface that by saying nobody has data that compares real time. And CMS doesn't even have data. They used to have this MSIS database that allowed you to go in and compare. They don't even have that up and running anymore, and they're not doing comparisons. So we're getting you the best data here. It's 2012, but I would venture to guess that hasn't moved that much. So this is a good idea to show you where we think you are. Now let's look at your cost for acute care, hospitalization,
When you say cost per resident, is that cost per Medicaid recipient, or is that cost per 3 million Arkansas residents?
It's based on the population of the state, and Truven uses U.S. Census data. Also, just for the record, we spoke to, through email this morning, the lead person on this for Truven, and they're expecting the FY 2013 data out early summer. We're going to get a copy of it right away, so we'll be able to update this. And also, just for the record, CMS funds this work by Truven. That's why it's CMS Truven.
And CMS does, I don't want to let the committee think they don't look at this. CMS absolutely looks at this and decides a lot of their own policy decisions based on some of this data. This is important because somebody on the committee had asked, okay, the acute care and the long-term care and some of the spending, where does that specific spending compare? And here's where you can see, again, this is from Truven. And if you look at, for example, your long-term care costs and the U.S. population, a long-term care is 28.4%, and that's looking at your Medicaid costs, how much is dedicated to long-term care, and you look at where you guys, or where Arkansas stands, and you're much higher than the national average. You look at your dish payments, where you are compared to the U.S. And if you look at that again, if I could summarize, the one thing we're seeing first month looking at all the data is I would classify Arkansas as a high institutional focus state. I want to be clear with the committee. That's what we're seeing in the data, and we are going to go out in the field, and we're going to meet with a lot of people and a lot of folks in the community, which means that you have opportunity. Look at it as positive. You have opportunity to look at community-based care and much more expansive community-based alternatives. And yesterday we met with the Nursing Home Association, a very productive meeting, and they indicated to us in an entrepreneurial type spirit that they understand the issues, and there are other models that they'd like us to consider when we recommend, like an ACO type Medicare model, where they can actually be in the business of offering home care. That was just from one nursing home provider who was a member of the association. We thought that was a plus. But we're not focusing on these categories because we're just wanting to make sure we show you what these other states do. It's what the data tells us in your state. And it could be that you know your state well. Richard and I can't wait to go to the Delta. We worked in Mississippi and helped them, and we got to meet a lot of people at low income. And we got to identify rural areas that don't have a lot of access. So what goes on in your state may be different than other states. So we have to also take that into consideration. And it may be that every region in this state can't be the same model. But at the end of the day, these are the things that you should be considering as policymakers. And finally, this slide is more the waivers. I started, I think, by telling you you have a number of waivers. And quite frankly, I don't know how Dawn and her team can manage all these waivers. And Craig and long-term care, having 3 waivers in his, I think it's 3 or 4, I don't know if he's still here. But at the end of the day, we've got to figure out a better way for them to also manage their own services. So with that in mind, Mr. Chair, that's again, a lot of those task force questions were the result of this presentation.
Thank you very much, John. Senator Chesterfield, you're recognized for a question.
Thank you, Mr. Chair. In looking at slide 31 and looking at the expenses per resident, concentrating on Texas, in comparing Arkansas to Texas, with Texas's high population, is it a fair comparison? And if it is, explain to me why.
Senator, I put Texas in there only because it's a surrounding neighbor state.
But I'm looking at the cost per, our cost per resident, because we have so few folks and therefore the money is spread around among such few folks, and then Texas is so low because it's spread among an exorbitant number of folks. How did we arrive at that? That's what's of concern to me, to make sure that we're comparing apples to apples in that.
Well, that's a great question, Senator. And as John said, We made a decision to just choose your neighbor states because they're the closest. John and I have spoken about this before the meeting, and there are other states that are comparable in population. There are going to be disparities between the states no matter which way you cut the cake. For instance, we could take a look at Connecticut, but Connecticut is about the highest income state in the country. For the start of the comparison, based on the questions that were asked of us, we decided to stay in the South and stay with your neighbors. Iowa would be a good place to take a look at. We can expand this. The purpose here isn't to make a qualitative judgment on any state, because you look at one Medicaid program in one state, you've only looked at one Medicaid program in the United States, because each one is different in fairly significant nuances. What's not different is the construction of what John's been talking about, which is the institutional to community balance in your highest need, multiply complex populations that are determining a good part of why your costs on a per resident basis, the per resident basis has some equalization value. It's not probably scientifically rigorous enough for my colleague, Dr. Oliver, and I'll stand corrected by him. But the point of the matter was, you spend what you spend based on the wisdom of the policymakers and the tax capacity of the state, regardless of what decisions are made. That's the bottom line, and that's simply why this data is here.
But there's one thing
It's not lost on me that we're higher than Mississippi. That is not lost on me. So I'm just trying to get at how it is that we arrived at it, because we're higher than Mississippi in cost per person, or cost per resident. So that's not lost on me either. Who or which states are numbers 1 through 10?
Well, we can get you that data, but I can tell
Which
you.
one is number 1?
New York State's number 1, and New York State's double the price you have here. New York State is an anomaly in the United States, even compared to California.
It's even bigger than California.
No, their cost per resident is, and they've got about, now it's a little less than half the number of residents of California, so go figure.
But a lot of it has to do with what they pay for their rates. There's a lot of things you have to look at, and we'll be able to get some more information as, what I would really like, Mr. Chair, is after you look at some of these states, and you tell us, okay, here are the states we want to we want you to focus on, and we can actually help you make that decision, because then we would like to say, okay, what do they pay their personal care attendants? Now, looking at Texas, now we know Texas, because we've done some work in Texas on the child welfare side. So we in the foster care area, we know some of the Medicaid foster care issues, and we know that they have in the age blind and disabled area, they have traditional managed care. And we know that they have managed care in the other population as well. And that may be some of the reason for some of the lower costs. But I can tell you another thing, and this isn't a pro-managed care, that they have low rates in some of their developmentally disability areas, some of their other home care areas. They have some of the lowest rates in the country. So that could be another reason why why costs are so much lower. So you have to look at the whole picture. Like, I think you're getting that picture. So, but I still think it shows something. It tells you that there is something going on here. And we believe it derives in large part by the high institutional focus.
Right. And thank you for that. And then my last question deals with an issue that we dealt with prior. The federal government has no definition of medically frail. And I know I'm going back. I write these things down so that when it comes to my turn, I won't be up too long.
Yeah,
The federal government does have a definition of medically frail,
I'm
but
gonna-
the administration is different. Is that not correct?
I'm going to get the answer for you. They use functionally, what is it, functional assessment. There's so many different terms they use, but I'm going to see if they actually use that term.
Right. We will get you a definitive answer whether or not the government has a determination of what medically frail or fragile means in terms of program eligibility, which I think is the root of your question. As John was saying, there's a different criteria for different levels of care, and even within the long-term care services, depending on what waiver you put in, the state does have some control, as John said earlier, over determining, for instance, how many adult daily living challenges a person may have. Some states may have 2, some may have 3, some may have 4. And that has something to do with it, but we will get a definitive
All
answer.
right, thank you so much, and thank you, Mr. Chair, for your indulgence.
Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. Following up on Senator Chesterfield's question on page 31, and I don't have it pulled up electronically, so I'm trying to read at the bottom. And it says, without knowing exactly the data set that was used for this report, are you, in future reports, are you, and this is page 31, are you going to give us somewhat of a criteria for comparison so that we do have the apples to apples of these other states that would say in this particular area it's this much? Because,
Yeah.
I mean, that statement right there almost seems to disqualify the validity of the numbers. And if we're looking at developing a plan as a task force that we're going to recommend to the citizens, I'd like it to be on good, solid numbers and not just for numbers like this.
Yes, we're going to do our best. The reality is, these are the only data sets nationally that you can go to Truven and Kaiser that we're aware of, to actually get this type of level of data. So we can find out what data they used, we can ask them. But what I'd like to do, and this is what I said earlier, is actually go to the states and extract the best we can their own budget numbers. Ask them to send us directly some of their numbers in terms of their budget, then make those comparisons as well.
Okay, so could you, just so we know we're on track, is it unreasonable to ask that if you were to go in and maybe take even one segment, you know, mental health or hospitalizations or whatever, and take Arkansas numbers and then get us like 10 areas of comparison so that we could have, you know, have a solid number to kind of gauge from? Is that unrealistic, or is that?
It's realistic.
Okay.
And we will keep you posted on those efforts.
And then last question to you, and maybe the chair would chime in on this. Earlier, we made a motion, accepted a motion that actually, in my opinion, imposed more work upon you, and I'm not sure that that was within the guidelines of the, you know, the original RFP, and you agreed to take on that additional work. I think that kind of set a trend for the next 6 months, so I'm curious that with that motion that we passed a while ago and that extra workload, do you consider that covered in your contract, or is that something that's going to drive up the cost?
We're going to be able to do that within our budget. The issue is, I want to be able to, Senator Sanders, I think it was, I want to give you the best recommendation possible on contract management, what we should do going forward. And I think that what Martha's going to do in that particular assignment is going to help give her the information she needs going forward to make her own assessment. So right now, I feel comfortable.
Thank you.
All right, folks, we still have 2 more agenda items to go. So next on our agenda is item H. John, you're going to talk to us about the timetable for scrubbing of the Medicaid rolls.
I'll be very brief. There's not much to really add to the fact that our beneficiary scrub subcontractor, LexisNexis, met with the department again, and I believe Delia Anderson is here from the department's eligibility unit. Her team has been so responsive. They're now going through the business associate agreements, and they're supposed to be getting the data soon. And if there's an issue, I will make sure that the chairman and through Jill knows about that right away. The only issue I know right now is our subcontractors' business associate agreement is stricter than the state's, because they also supply data to the state police and to FBI, and they have a large database, and they have legal requirements that far exceed even some of the HIPAA requirements. So it's between lawyers and lawyers right now, and whether the state is able to accommodate where they want to be, and that's the only issue. And I know that we'll let you know if there's a problem. And the other subcontractor, Acuity, same thing. They're going through the documentation process right now, which takes a while.
So, Representative Hammer, you're recognized for a question.
Your earlier conversation today had the question of the 4,000 that weren't receiving the mail pieces and how that was going to impact the numbers. So will the scrubbing of the Medicaid rolls also likewise impact the numbers And if it does or won't, what kind of time frame are we talking on that you, and I know the lawyer-to-lawyer thing, but if you had to give us a good guesstimate.
Yeah, it's a good question. It's not going to have any impact at all on it's a separate issue, the redetermination. This subcontractor we have is going to scrub independently the entire beneficiary file. And they're going to come back to us and say, we have, let's just use this example, we found 20,000 that addresses don't match. And that's going to at least enlighten us that maybe there's even a further problem. Or they might say, there aren't as many as we think. But they're going to do their work independently.
Okay, and those that will be disqualified because they don't meet the eligibility, will it, help me understand, is it possible, or is it now that the insurance companies are receiving premiums on those, even though that they may not meet eligibility, that they're going to be, flushed out in the scrubbing process?
That depends on what we find.
Okay.
But I will tell you, Representative, it also depends on whether we can get access to there's one other database, which is the income, that wage database. And Phil is helping us to set up a meeting with your Department of Workforce. We need to get that access to that data to look at and compare on the income side. As far as the identity and residency and also property and assets, we'll be able to look at that. And so to answer your question, it depends on the database we get. And hopefully we're going to be able to get that workforce database to look at.
Question of the chair. Could we find out, would you allow Phil to enlighten the committee why is it just a matter of logistics of timing, or are you meeting resistance and getting cooperation out of Department of Workforce Services?
Phil, you may, Phil's been great. They're just sending a letter to them now.
Okay.
I don't perceive any issues. Phil might want to answer the question later.
Okay.
All right, thank you very much. No more questions on that subject. We'll move to our last subject, item I, geography of Medicaid. Shelby Johnson, appreciate your patience with us today. I know you took this spot understanding it may or may not happen, but I know you've been here all day, so I want to make sure we get a chance to do it. So please introduce yourself with your name and position for the record, and you're recognized. Talk about the Medicaid geography information you want to share.
Good afternoon. Thank you, Mr. Chair. My name is Shelby Johnson. I serve as the State Geographic Information Officer for the Arkansas GIS office. And I hope that I realize that I'm between you and going home. So I don't want to short.
A lot of people are going to be here tomorrow, and people can come and go as they please. So I recognize that it is what it is, but please, we're always hungry for good information.
Well, it is what it is, so I'll try to go fast, but I have a problem with talking fast. I'm not very good at it. I want to show you some work that we did back in 2012 that I think may be beneficial for the committee. In that run-up to the tail end of 12 and the beginning of 13, the Beebe administration had asked our agency to do some work on being able to help them just understand where in Arkansas is Medicaid recipients and providers. And they were using that to kind of inform themselves as they were preparing for the 13th session. We worked with Director Seelig and the Information Technology Group at the department, and what we did was we pulled an extract of the fiscal year 2012 data from the payment system. So we had the client address and the client dollar figure associated with each client. And then we did the same thing for the vendors. And so the result was we did a massive effort to map all of the Medicaid clients from the 2012 data set. So it's 777,000 total records. We geocoded all those. We ended up with 761,000 of those records inside Arkansas. or about 13,000 records that fell outside of the state boundaries. And that's a case where, let's say that you've got an elderly person that's in Manila, but they might have a son or daughter that moved to West Plains, Missouri, and that son or daughter takes care of their financial information, and so the mail address would go into West Plains, Missouri, but the client actually is in Arkansas. So that's the nutshell on that. We had about 2,000 records in that that we couldn't map or couldn't locate, and that's a function of partly our work in the 911 addressing with the counties. There were some counties where we don't have that good data yet. If you look on the map, you can kind of visualize where Newton County, Arkansas is. You can see it's really sparse there. That's a function of we didn't have very good GIS data for that part of the state. We have a few places like that, Scott County being another example, Senator Rice, where the data wasn't as good then as it is now. So once we were able to take all of these client data and put them to the ground, then we could then summarize those by legislative district. And so that was the rest of the analysis that we conducted, just to be able to summarize those by legislative district, to be able to characterize this data in a way that would be meaningful to you. What you're looking at here is the number of clients per Senate district. Senator Ingram, might not be any surprise to you, but you're the highest district in the state, I believe. I may be wrong. Senator Chesterfield may actually be a little bit higher. Let me pull out my glasses so I can read this, sorry. Yeah, so Senator Ingram's district, for example, 34,005 participants in the program. And again, these are not exact numbers because there may have been a case where some of the data we couldn't exactly map perfectly, but these are pretty good for the quality of the data that we have in our state. And then, interestingly enough, Senator David Johnson's district in the western part of the Pulaski County, West Little Rock, that's the lowest district. So Senator Johnson has 11,283 clients, again, from the 2012 fiscal year. So that's just clients by district. Then we looked at the percentage of population. So each of you know that on the Senate side, your districts average about 83,000 and change on your population from redistricting. So you can take a look at like Senator Rice's district, 33% of his population for that district is enrolled as a Medicaid client. Senator Chesterfield, for example, 40%, and then I'll point out Senator Ingram's as an example, 39%. So that's pretty high. Senator Chesterfield's was the highest on that particular chart. And I believe, again, Senator Johnson in western Pulaski County, West Little Rock, had the lowest percent of his population that were parts of Medicaid. I'll make sure I stay on the same slide as on my paper here. Sorry about that. All right, then we started looking at the payment data, and the payment data is just the dollar figure associated with each dot. So from the extract that pulled out of the Medicaid database was the address and the dollar figure, and we started summarizing those dollars and then summarize them by the legislative district. And then this just gives you a picture of the payment by a Senate district. I should add, we did this for the House districts as well, but I didn't want to make a presentation that would last a lot longer, so I'm just showing you the Senate district maps for illustration purposes. But you can see that payments by Senate district up there pretty high is, again, some of the districts in the south central part of the state. For example, Senator Malek's district, 136 million in that district. I think Senator Hester in northwest Arkansas is probably the lowest. Was at 44 million in payments into that district. Senator Bledsoe, for example, yours was 71 million. It's an interesting thing you'll see, for example, Senator Ripert's district. If you look at it in central Arkansas, that's where the Human Development Center is in Conway, and so you can see his is a little higher than the surrounding areas, and so that's probably a factor of that Human Development Center. Moving forward, I want to mention this, just give you an average. The average payment by Senate district was $103 million per per Senate district on the client side. We'll look at the vendor side in a little bit because the vendor side changes. So this next slide goes into the Medicaid vendors by Senate district.
Before you
and-
move on, we've got a question here. Senator
Yes, sir,
Chesterfield.
sorry.
That's all right. Senator Chesterfield, you're recognized for a question.
Thank you, Mr. Chair, and Shelby, good to see you.
Good to see you.
He has done invaluable work for us on the 911 task force, and I just want to say that for everybody. But I can't read my district because I don't know how I'm doing that. Maybe it's because it's too small, or I'm not finding the Senate stuff. Could you send that to me?
Yes, ma'am.
I'd appreciate it very much.
Be glad to. Members, I apologize. The fellow who made these particular maps had better eyesight at that time and didn't make the font big enough, so my apologies.
I think it would be helpful if you would just send, you broke it out in a big map. We have a big map of the House districts with their names, but I didn't see a similar one with a big map for us in the Senate.
I did not add that in, but we could get that information to Phil.
All right, and I appreciate you very much because we found out so much dealing with the 911 task force about what you can do and what we still need to know, and I appreciate it. Thank you, Mr. Chair.
Thank you. Any other questions? All right, I'm going to move on along. So then we go to the Medicaid vendors by district, and I kind of want to draw your eye to Senator Files' district there in Fort Smith. You can see that, for example, he's got a fairly large healthcare system there with the Mercy Health there in Fort Smith. So you can see that's a small Senate district, but a pretty high count of vendors. And I would attribute that probably to the healthcare system that is set up to support the Mercy there in Fort Smith. You can kind of see a similar trend in Senator Wood's district and Senator Lindsay in Northwest Arkansas with the Fayetteville-Springdale area and all the health centers and the health care that's there. But you kind of trend your eye over to Senator Ingram's district, and he's got 456 providers in his district. So these are your Medicaid vendors that we mapped. On average, every district has about 312 Medicaid vendors on average.
What is a Medicaid vendor specifically?
They received a payment on behalf of a beneficiary or
Is it
a
primarily
participant.
physicians, or can it be clinics, or?
Now this is the part where the GIS guy doesn't know the answer.
Okay.
So we mapped it, but I would have to defer to John or his staff, and I don't see John's here, but
Okay.
it would be, I would assume it would be physicians, facilities, the other businesses that support healthcare, but I don't know for certain.
Yep, okay, thanks. Yeah, I'm gonna ask John, kind of send an email to clarify that, because I guess they probably just pulled it from the provider numbers or data or something, but maybe what that is.
Yes, sir. I'm going to move forward. So then we go, I want to back up really quick and say, okay, that's just a raw count. In other words, we mapped the vendor locations or mapped their physical address, and then we just summarized it or totaled it by the Senate district. So, for example, there, Senator Hendren, you got 127 vendors in your Senate district. Okay. The next thing we did was we took the dollar figures that track with those vendors. And so this next map is your vendor claims by Senate district. And so if you look at, for example, again, Senator Hendren's district, I know this might be a little difficult for you to read because of the way we printed it out for you, but Senator Hendren's district, those vendor claims, again, this was 2012 physical data, was 19 million in Senator Hendren's district. You can see the award winner, Senator Chesterfield, and I would attribute that to Children's Hospital as being the highest district in terms of total vendor claims. I guess one of the things to point out there is that the vendor claim, while you have the participants, let's say you've got a participant that's probably the easiest way for me to explain this would be like in Senator King's district, Berryville and Green Forest. Well, they may go to receive their health care in Springdale or Fayetteville, or they may go back to the east to the facility there in Baxter County in Mountain Home. So on the claim side, the dollars are following where the health care is at to some extent in terms of the geography of the dollars. And that's part of what you're seeing there. Interestingly enough, you'll see a pretty good trend there between Senator Malik, Pierce, and Cheatham in the south part of the state, and also Senator Clark's district as well, where they all fall in about that $110 million range in terms of vendor claims in those districts. The average claim per Senate district, if you just average it statewide, is 99 million in claims. And then the final thing we did, which this was not part of that obviously not part of that 2012 effort, was to actually just do a geocode of the private option. We had anticipated that that might be something you might want to see someday. And so that's in the fold-out map. The table to the right just lists the raw numbers. I showed you the House district here because it did a better job of illustrating a geographic trend that some of you might have predicted, which is that you had fairly high enrollment in the Delta. If you look at the raw numbers on the chart on the right, that just gives you
Excuse me, so I just make sure I'm following. If I look at House District 84, that's my district, it's right down near the bottom, meaning I don't have many private option people in my district. Is that correct? Way to look at this chart relative to the other districts?
Correct.
Okay,
You're in that bottom rung on private
Okay.
option.
Okay, good. I'm out then.
Representative Hammer, you got a question? Okay. All right.
And so that really is just a real quick run. We could certainly provide the House side maps, but we just thought that that would be something that might be of some value to you to understand, geographically. And I visited with John, I guess it was Monday or Tuesday when I found out that we were on the agenda, and I was careful to ask him, has the data changed that much? So, if you look at this from 2012 to now, does the data change that much in terms of some of these maps that you see in Medicaid? Again, all of the previous maps were all Medicaid. And he said, probably on balance, it probably doesn't change that much. There's some shifting here or there, but it's probably minimal when you're looking at summarizing it up at a Senate or a House district level. So anyways, I'll stop and thank you for indulging us on having an opportunity to share this with you.
Well, excellent presentation. We've got a couple questions here for you. Representative Hammer, you recognize.
Thank you. I was wondering if you could tell me, Shelby, on the last one, I can't read the numbers. What's the total private option enrollment number, or do you have it totaled up on that map somewhere?
I did not total it on that map, so I don't recall the exact number, but it was upwards of 200,000.
Okay. And all this data was provided to you by DHS, is that correct?
Yes, sir. Yeah,
Okay.
they were really good to work with us, and it was interesting for them to be able to see their data visualized on a map too. So I think they were pretty excited about that project.
Okay, and back to page 2 on the one that shows the distribution of Medicaid clients in Arkansas. If you don't know the answer to this question, we'll ask them, but it talks about 777,000 Medicaid records were processed representing claims during the 2012. You know what that definition of claims was? Did they discuss that with you?
No, but they all agreed at the time that that was the right data set to run. So in terms of being able to visualize the geography of Medicaid clients in Arkansas, that was the data that they presented us.
So is the number of Medicaid recipients equivalent to the term claims that's used in that diagram, or do you know the answer to that
I
question?
do not know the answer to that, Representative Hammer.
Okay, all right, thank you.
Representative Flowers, you recognize.
Thank you, Mr. Chair. Excuse me, everyone. I'm regaining my voice, so if you'll indulge me. I just have a couple of questions. I'm wondering if there is a similarly formatted map like what you have for the House that illustrates that for the Senate as well. And I'm just interested in seeing how that fleshes out in my area when it's expanded to my Senate district, or my Senator's Senate district. And then my second question, well, let me let you answer that first, and if I could have a follow-up, Mr. Chair.
Yes.
Okay.
And we can get that to Phil.
Great. And then secondly, I was really interested and found interesting the information that was provided in the models that you had from 2012 in the Senate, and how that might apply with even more information to provide context to these data that you've provided in this enrollment map regarding the private option. And to be more specific, like when I read these numbers, they really tell an interesting story, or they really give an interesting picture, but I'm interested in the story as it relates to minority health and as it relates to the social determinants of health. So for example, it was recognized that a lot of the highest numbers are in the Delta, but then there are other areas that are not in the Delta that have a difference of 150, 200 enrollees. And so it kind of begs the question, what are some of the patterns in terms of unemployment, in terms of median income and those kinds of things, so we can get an understanding of what some of the commonalities are with some of these areas where we see higher enrollment.
I want to kind of take you to two different things. Number one, when you look at the thematic or the numbers that you see on the map that's on the screen right now, bear in mind that's exclusively private option enrollment as of January. That doesn't add to the numbers that you see, for example, on these maps. These maps were Medicaid alone from 2012. So if we took both the private option numbers and put that with the Medicaid alone numbers and then remade that map, I would speculate that on the House and the Senate, the number, those maps, if we added the private option numbers that are on that very last page and added them to this page that you see on the screen now, I would speculate that the map probably wouldn't look much different on the Senate side. And if we did that same thing on the House side, the map wouldn't look that much different. And being your geographer for the state, my speculation is that it's mostly a function of poor. It's mostly a function of poor, and then the second function, particularly on the private option side, but the second function is elderly. And that's really the two, that's the determinants.
And I would tend to agree, but I think that it would be valuable, and I'm not on this committee, I'm on another committee that's looking at Medicaid specifically. It would be valuable for me to be able to see that in black and white, or in this case in blue, black and white, in terms of those things you point out. And also just some added information. I guess my real question is there the capacity, and would I be able to work with you to ask it for something that specific, or would I need to, and I guess, Mr. Chair, even though I'm not on this committee, would it be more appropriate for me to go through the committee that I am serving on, or the council that I'm serving on, to ask for some specific data so that I can get it?
I'm sure that you'll accommodate requests for data. You know, just as a legislator, you're welcome to go through the chairs and have us copied on it, or just ask it direct, but certainly we never can have too much data.
Thank you.
We'll be certainly glad to get the Senate map that shows the large foldout that we presented that was on that last page. We can get you that fairly easy. The one thing that I would not do, because it would be oranges and tangerines, is to try to blend the 2012 data with the private option data. And we really, given our new situation after the unfolding of the special session, our plate's a little full right now, so it would be very difficult for us to repeat this work that we did in 2012 in a timely manner.
Are you finished, Representative Flowers? Senator Chesterfield, you recognize.
Just a point of personal privilege, I would ask that we put the thing back up on the screen so that you see the big humpback whale in the middle of the state. That's me. So the next time anybody talks about how wonderful it is just to be in Little Rock, please understand that those of us in Pulaski County are not always just in Little Rock, and that the difference between Senator Johnson's district and my district is rather phenomenal.
Yeah.
He lives where people are very rich. I live where people are very poor. And that's evident by that. And please know that I go from Jacksonville to the Jefferson County line. Thank you.
Thank you, Senator Chesterfield. And I'd like to second what she said. This is incredibly intuitive data for us to have, and I can see a lot of potential uses for it. And I guess what I would ask you is, do you have this data in a field where you can do sorts and apply different conditions to it? For instance, if we said, can you show us the claims of children or the claims of folks that are in the disabled, blind
No.
population?
No, we do not. And I'm glad you asked that question because it allows us to explain something that's very important. At the time when we pulled this data across, there was concern about confidentiality, privacy concerns. And so part of our agreement when we worked on this with the Department of Human Services was to redact out everything else. So when we pulled the data across and actually did the mapping, we got address, city, state, zip, and a dollar figure. And that's the only data we ever possessed.
But
technically, yes, we could slice it and dice it any way you wanted if we had unfettered access to all of the data.
On the provider data, for instance, if we said we would like a 10-mile circle around every Medicaid provider that meets certain criteria, if you had that data, you could plot that and give us that type of information.
Sure.
Okay, again, I appreciate the presentation because I think it does have some tremendous value as we start trying to look at a delivery model and strategies about how we make sure folks have access to health care. And Senator Chesterfield, your point's well taken. There is a tremendous, I mentioned that to the co-chair, it's amazing the difference between a few miles makes in some of these districts. So it's very, very good data. Members, that's all we have on the list, and that's all we have on the agenda. I want to thank you all for sticking around for a long day. I appreciate your diligence. The good news is we're done. The bad news is in July we're going to have 2 days of this in a row. But thank you all again, and thank you again, Shelby.